that you are. Know that there is something inside you that is greater than any obstacle. Honorable HOD ma'am, respected teachers, seniors, delegates, my dear colleagues and juniors, a very good morning to one and all. It is my pleasure to welcome you all to the 14th Practical Pediatric Endocrinology course being organized under the auspices of Department of Pediatrics KGMU Lucknow, Grow Society and Medi Classes. We have assembled a panel of renowned speakers and faculty who will share their expertise and insights on the latest developments in pediatric endocrinology. Through this event, we hope to foster a culture of continuous learning and improvement among healthcare professionals. We have a formal inauguration planned at 12 p.m. Without much delay, we would like to begin with our academic sessions. Our first session is about glucose, diabetic ketoacidosis, and hypoglycemia. With great joy and enthusiasm, I would like to welcome on stage Professor S.N. Singh sir, who is the chairperson for the first two sessions. Sir is professor at the Department of Pediatrics, KGMU Lucknow. And the second chairperson, Professor Krishna Kumar Yadav sir. Sir is an additional professor at Department of Pediatrics, Ram Manohar Lohia Institute of Medical Sciences. So please.
Okay, good morning. It is a pleasure to invite Away, who has several publications, and he is co-author of the Basic Pediatric Endocrinology and Advanced Pediatric Endocrinology. He is presently working in I don't see where. No, that is the fellowship. Where he is working?
He's done his fellowship from Regency Kanpur and is currently the director and consultant at CPED, Rajkot, Gujarat, and he's a secretary, Rajkot Academy of Pediatrics. I welcome you, Dr. Chetan.
Presentation. So good morning, Lucknow. Fine, so I have been an opening batsman and I have been given a task of scoring more than 60 runs in first power play, because DK is a vast topic and it will take more than 1 hour, but I will try to finish in 15 minutes. So as we know, the DK means diabetes, ketosis and acidosis. So to diagnose DK with all three, and that will be discussed in our presentation. I will touch base on the pathophysiology, what can be the ideal management, what complications can arise from the condition itself, as well as improper management, and how to deal with those things when it arises. Okay, fine. So as we know that type 1 diabetes occurs due to insulin deficiency. But to develop DK, it is not just the insulin deficiency which is required, but we need also excess of stress hormones, or we can say counter-regulatory hormones. We know that in our body we have one hypoglycemic hormone, that is insulin, and we have 4 hyperglycemic, or you can say stress hormones, that are glucagon, epinephrine, growth hormone, and cortisol. So whenever insulin deficiency occurs, there will be hyperglycemia leading to ketone body formation, and we call it as ketosis. And this ketosis will result in acidosis, and we call it ketoacidosis. But this is not all. Whenever we have insulin deficiency, we will have high sugar, which will leading to glycosuria, and the sugar will be lost from the kidney. So along with this sugar, water, sodium, and other molecules also go out. This will result in depletion of the intravascular volume, leading to high stress hormones. And this stress hormone again will accumulate hyperglycemia, and this will result in more of a high sugar, more of a ketone body, and accentuation of the ketoacidosis. So to develop DKA, only insulin deficiency is not required, but you should also have excess of counter-regulatory hormones. And this is the reason why pure DKA without any complication will not have any shock, because of this high counter-regulatory hormones. So you must have observed that whenever there is severe DKA, their pulse will be good with volume, force, and tension because of this high counter-regulatory hormones. So what happens after DKA develops? So there is glycosuria, urine will have lots of sugar, sodium maybe, and water. This will lead to dehydration. But usually in DKA we tend to overestimate the dehydration. Why? Because the baby is sick looking, baby is breathing heavily, there is lots of retraction and all. So usually our advice is to calculate one step lower as far as the dehydration is concerned. Another thing is pseudo-hyponatremia. Because of the excess glucose, maybe excess lipid, we tend to have low sodium at the onset of DKA or at the admission. But we should be calculating corrected sodium. So with each 100 milligram of rise in sugar, there is deficit of 1.6 millimole. Some say 2, but nowadays we can say 1.6 millimole of decrease in the sodium happens. So we should be calculating corrected sodium. And the goal of management should be this corrected sodium should remain constant. If your corrected sodium falls, then you are probably going towards the cerebral edema. Another thing is potassium. Now we know there is potassium proton pump, which is regulated by the insulin and is also manipulated by the acidosis. So insulin deficiency as well as acidosis will push hydrogen into your cell and will push out potassium from inside to intravascular space. So you tend to underestimate the potassium deficit, because whenever you start the treatment, the reversal will occur. The potassium will go inside the cell. So there is chance of hypokalemia, and this is the reason why we should add potassium in each and every fluid. So now whenever you start the treatment, first of all you should be correcting is normalization of intravascular volume. So you should be starting IV fluid, and whenever you give IV fluid, say you can say bolus, there will be decrease in the stress hormones. So along without insulin, there is a decrease in 100 to 150 milligram of glucose by just giving the bolus. And this is the reason why we don't advocate insulin in first hour or first half an hour of the therapy, because sudden lowering of glucose will again result in the increase in stress hormones. So first 30 minutes, maybe 1 hour, only fluid, that is NS, 0.9 NS, and then after we start the insulin. So whenever we start the insulin, what will happen that there is resolution of ketosis, there is resolution of acidosis, and this will take 6 to 24 hours depending on the severity. But suppose if we overtreat, say if we give high fluid, if we give so much of bolus, or suppose patient has come by taking some 500 ml or 1 liter of fluid from the outside, then there is a chance of osmotic shift leading to cerebral edema. Plus if we give high normal saline, there are chance of hyperchloremia. So this is all are the complications. Plus if we give more of an insulin, there is a chance of hypokalemia. And in our own study, we found that the hypokalemia on admission and outside history of IV fluid are the main culprit, or you can say risk factors for cerebral edema. So nowadays paradigm is shifted from high fluid to a bit of lower fluid, and to high insulin to a bit of lower insulin to maintain the potassium in the normal range. Now what are the complications which can arise from the DKA? The most dreaded is cerebral edema, It is usually associated with the severe disease, too much of the fluid, installation or giving soda bicarb, as well as osmotic shift, which can happen from the rapid push of the IV fluid. It is associated with high motility, high morbidity. So we advise use of mannitol whenever you diagnose the cerebral edema, and we have strict criteria for the diagnosis of cerebral edema. So I would recommend you should have in your PICU and your emergency department the printout of that cerebral edema criteria. So if the child fulfills that criteria, that is different for kid who cannot speak, and that is different for the elder children. If you find cerebral edema, you give straight away mannitol along with less fluid and slow correction. So maybe you can reduce the fluid to correction over 72 hours, or maybe you can reduce to 2/3 of the fluid along with the mannitol, and the mental condition should be assessed every 1 to 2 hourly. Another problem is hypokalemia, because patient can die of hypokalemia. Patient will not die for the persistent of acidosis. So we should be supplementing with the potassium in each and every fluid. And if the patient has report of hypokalemia on admission, even you can add the potassium in the initial resuscitation fluid as well. Another complications, or you can say that is persistent of acidosis, that might be due to persistent of decay by any reason. Number 2 is infection or sepsis, and number 3 is high chlorine. We'll discuss how to approach this persistence of the acidosis in subsequent slide. Another is sepsis, infection, thrombosis due to high lipids and hyperosmolar intravascular volume, and rhabdomyolysis due to hypokalemia, hypophosphatemia, and hypomagnesemia. So as I discussed earlier, the criteria should be diabetes, that is random blood sugar more than 200, ketosis. Beta hydroxybutyrate is the most important ketone, which is first to come and first to go. So we should be measuring beta hydroxybutyrate as compared to our acetone, particularly urine acetone or urine ketone, which is last to come and last to go, and which is not correlated with our therapy. And nowadays ketone meter is also available, which can measure the bedside ketone just by the finger prick. So I would recommend to use that ketone meter, because it is also helpful in the monitoring of the therapy as well. Also, there should be a presence of acidosis. So if all three is present, then it is your DKA. There is only ketosis and acidosis without having high sugar. It might be due to some metabolic or high anion gap acidosis like organic acidemia or post-vomiting as well. If it is only diabetic and ketosis without acidosis, then there might be a sick day in case of already known case of type 1 diabetes. If hyperglycemia is associated with acidosis, then this might be a case of stress hyperglycemia. Now, whenever DK patient comes to you, the first step is ABC, of course. So you have to secure the airway. You should insert the NG tube, because many times it happened that some relatives that might have given sugary drink to the patient because they feel that the patient is falling sick and patient is losing weight. So there are chances that sugary drink or sugary water or sharbats might have been given. So you should be emptying the stomach by inserting NG tube. You should remove that NG tube to make the patient comfortable. 2 wide bore IV lines should be taken. Oxygen is SOS, because we know that this respiratory distress is due to acidosis. It is not due to any lung issue. Avoid intubation, because it will increase the what you call intracranial pressure, and there are chances of cerebral edema. Thrombosis, so avoid central line and avoid volume overload. Danger signs while we are treating the DK is shock, because as I told you earlier, there should not be shock while in a patient of DK. If it is associated with shock, then there are chances of sepsis, infection, or maybe renal failure. If you find any ECG changes suggestive of hypokalemia, you should be wary, because this is another dangerous complications. If it is sepsis, then you can give antibiotic. If it is cerebral edema, signs of cerebral edema, you can give mannitol along with slow correction. You might find hypertension, which can occur in 10% of the complicated patients with acute kidney injury or cerebral edema. And high total leukocyte count and high amylase lipase are a normal, you can say, associations of DK, and it is not associated with usually pancreatitis. Also, you can find lipemic serum, which gets normalized with the insulin treatment. Many times you find that the triglyceride might be in 2000 or 3000s, but you don't need to treat for that hypertriglyceridemia. It usually corrects with the insulin therapy. So fluid bolus, I think each and every patient will be helpful after receiving the fluid bolus. particularly if it is associated with tachycardia, dehydration, dry tongue. Dose is 10 to 20 ml per kg. Ideally, we recommend only 10 ml per kg of single bolus. If at all you feel to give a second bolus, you should ask your head of department or head of unit before giving the second bolus. That is the dictum. It should be given over 30 minutes, maybe 60 minutes if it is associated with the history of outside fluid already taken, and you should deduct from the initial fluid. Avoid more than 2 bolus, and first 4-hour management fluid should be less than 40 ml per kg. Now after first hour of treatment, there comes another phase which is to be given in 2 whiteboard lines, one for insulin and one for IV fluid. So to calculate, you should calculate maintenance, that is your holiday cigar formula 4 to 1 ml or 150 and 20 ml per kg, and deficit. Deficit is to be calculated according to the condition, or BSPD formula says that if your pH is less than 7.1, you can take as 10%. If your pH is more than 7.1, you can take as 5% of the deficit. Normal saline, you have to counter check or cross check. It should not be more than double maintenance of your IV fluid rate. And if the patient is obese or more than 30 kg, you can calculate as 1.5 liter per meter square of normal maintenance. For the lower chlorine, you can use Hartmann solution as well. Now regarding the use of insulin, it has to be given intravascular, IV, continuous drip. Regular insulin is the only which is advocated, but if you are in a resource poor setting, you can use intramuscular injection of regular insulin, that is 0.3 unit per kg every 4 hourly in a very resource poor or remote setting. If you are using IV, then you start with the 0.05 to 0.1 unit per kg per hour. Tell nursing staff to flush the tubings, because 10 to 15 ml will be there in your tubes. So definitely you should flush the tubings and then you should start the IV insulin. It should be slowly changed. Avoid over dilution of the insulin. Maximum maybe 50 units in 50 ml of the syringe. Monitoring consciousness should be improved. Dehydration should be improved. And urine output should be around 1 ml or more than 1 ml per kg per hour. Your corrected sodium should remain stable. Your potassium should be above 3, preferably above 3.5. And your ketones should be nil by 6 to 8 hours, and acidosis should be nil by 48 hours. Potassium, as we know, the potassium is the most important as far as the monitoring is concerned. Even it has got more importance than sodium. So hypokalemia should be avoided. If your potassium is less than 3.3, you should add 20 millimoles per liter. If it is normal, then 40 millimole per liter, and if it is more than 6, then and then you should avoid. Or if you are having ECG changes suggestive of hyperkalemia, then and then potassium should be avoided. Otherwise, it should be there in each and every IV fluid. Dextrose, again, because we know that whenever your sugars falls below 100, your counter-regulatory or stress hormones tend to increase. So you should be avoiding hypoglycemia while you are treating a patient of DKA. So you should be starting dextrose therapy early. Whenever your sugar falls below 300, you should add 5%, and whenever your sugar goes below 200, make it as 9 to 10% of the dextrose containing solution. Last is bicarbonate. As we know that there are only very few limited indications as far as the bicarbonate is concerned. If there is life-threatening hyperkalemia or as a part of resuscitation only, you should use soda bicarb. Otherwise, you should avoid sodium bicarbonate as far as the recent guidelines say. So, if your ketone is more than 2, it means you are persisting DKA, and you should increase the insulin, maybe readjust the fluid. But if your ketones are negative, then you should calculate your chloride load. If chloride load is more than 32, it means it is hyperchloremic metabolic acidosis. Your kidney, the patient's kidney will wash away all the chlorides, and maybe you can reduce from 0.9 to 0.45 DNS or 0.45 NS if there is hyperchloremic metabolic acidosis. If it is below 32 with negative ketone, then there are chances of lactic acidosis. This might be due to renal failure or sepsis. Phosphorus is another important parameter. Low phosphorus is dangerous because it is an intracellular molecule. Altered sensorium, myopathy or rhabdomyolysis are the dreaded complications of hypophosphatemia. And if hypophosphatemia occurs, you should supplementing with the potassium phosphate, that is POTPHOS, which is now freely available. Of course, you should go for calcium monitoring as well, because whenever you treat with the phosphate, there are chances of hypocalcemia which occurs. And this is our own study published few years back, and which we found that the cerebral edema most importantly occurs around 24 hours and after 42 hours of the treatment. And early or outside history of fluid, severe decay, pH may be less than 7, as well as hypokalemia on admission, these three were the risk factor of the study outcome. So remember these three things. So decay, first hour, only bolus. After that, phase 2, in which you should be given IV fluid along with the insulin. Insulin 0.1 unit per kg per hour. If it is resistant decay, say bicarb is undetectable, you can go up to 0.15 unit per kg per hour, and then quickly come down to 0.1 unit per kg per hour. Add potassium, only no potassium if there is renal failure or ECG changes suggestive of hyperkalemia or potassium more than 6, and add dextrose as early as possible when your sugar goes below 300. So if you calculate, your sugar should be below 300 by 5 to 6 hours of your therapy. So ask nursing staff to make a ready of DNS solution along with added KCl. This will help your in the management of DKA. No bicarb unless and until there are 1 or 2 indications, and beware of cerebral edema. Okay. So along with this, I would like to end the discussion of DKA. Thank you very much.
Carrying forward the discussion, I would like to invite our panelist for this session, Dr. Arisha Alam. Ma'am is an assistant professor at Department of Peadiatrics, KGMU. Dr. Neeraj Anand, sir is an assistant professor, Department of Peadiatrics, KGMU. And Dr. Lokesh Sharma, sir, from Medanta Hospital, Lucknow. Sir, please be seated. For the case presentation, I would like to invite Dr. Dhwani. She is a fellow at Regency Kanpur in Pediatric Endocrinology. Ma'am, please.
Good morning to one and all, and let me start off with the cases. So we have a 4-year-old girl who'd come with severe DKA, was managed as diarrhea in view of pain in abdomen and vomiting, and was referred. At presentation, she had pH of 6.8, bicarbonate of 4 millimoles per liter, and ketone of 7.1 millimoles per liter. She was drowsy and had anisocoria, and on examination had brisk reflexes. So I'd like to ask Arisha ma'am, so what does this look like, and do we commonly see CNS manifestations at admission, or what could have caused CNS manifestations at admission here?
A very good morning to all of you. So here, as we can see, the child is 4-year-old girl with severe decay. She is presenting with features on examination, drowsiness, that is, the sensorium is dropping, anisocoria and brisk reflexes. So this gives a picture of raised intracranial tension, which likely is due to underlying cerebral edema. So now the second question is, how commonly we see cerebral edema at presentation in a child of DK? It's not a very common finding. In about 0.5 to 1% of patients at presentation, we may find cerebral edema. Then what are the risk factors which might have led to cerebral edema in this child? So we can classify those risk factors into 2 types. One is treatment related, the other is intrinsic or the disease related. So the treatment related are, as previously discussed in the presentation, higher volumes of fluid given within the first 4 hours, very rapid fall in the serum osmolality, or there is failure of an optimal rise of sodium, what we expect. Then if we have given bicarbonate therapy or insulin within the first hour. So if we look into this case, she was managed as diarrhea outside, so there is a high likelihood that extra amount of fluid might have been given with a rapid shift leading to this cerebral edema. Now secondly, into the intrinsic causes, they are less than 5 years of age, severe decay, that is severe acidosis, longer duration of decay symptoms to presentation to the health facility. So here in this child, the girl is less than 4 years, it is severe decay, so intrinsic factors are also present. Should I
Yes.
come to the management?
Yeah, how do we manage this case here?
So we have to manage it very urgently because it is a very dreaded complication carrying high mortality of about 25%. So immediately mannitol has to be given 0.5 to 1 gram per kg in this child. Second prong of the management will be how you will alter your fluid, how you will give your fluids. So you have to give a slow correction of fluid over 72 hours as compared to the standard 48 hours.
Thank you, ma'am. So very well pointed out. Someone who has already received high volume fluids previously is at very high risk of cerebral edema at presentation. This is something we should be wary of. Subtract that the amount of fluid that they have received when you give the correction dose of fluid subsequently. Moving on to the next question, we have an 11-month-old boy who had presented with failure to thrive. On investigations had a pH of 7, ketones 4.4 millimoles per liter and RBS of 440. So this boy now meets all the criteria of metabolic acidosis, hyperglycemia and ketosis. So I'd like to ask Lokesh sir, how will we go about in this case?
Hello. Yes. So it fulfills all the criteria of DKA, and as already started in first question, we have several risk factors here already. Child has failure to thrive condition and severe DKA, and he is infant, like less than 1 year. Less than 5 year old children have extra risk of cerebral edema, and less than 1 year, lower the age, higher the risk. So we need to be very careful. We'll start with the saline bolus first, and after 1 hour of saline bolus, we will start with insulin therapy, and we will keep monitoring. We will keep monitoring all the parameters and CNS examination, and we will be more careful that insulin dose should be. Now that Dr. Chetan also had just slightly brushed around that topic, that insulin is now shifting to 0.1 to 0.05 to 0.1. Now standard guideline also says 0.05 to 0.1. And especially it is true in the younger children. Because rapid correction may lead to risk of cerebral edema, and slower correction does not lead to anything. So if we are in hurry of correction, if child is in shock. If child is not in shock, then we do not have any hurry. Slower the correction, lesser the risk of cerebral edema. So we will give 0.05 unit per kg per hour of insulin dose, and we will correct it slowly. So that is 72 hours. So these are the things we need to be careful in this case.
Thank you, sir. So next we have a 9-year-old girl who is emaciated, again meets the criteria of hypoglycemia, metabolic acidosis and ketosis. So my question is for Neeraj sir. How is this case managed differently from the previous 11-month-old child?
So this child is emaciated. So in this case, there are more chances of, as we already know that malnutrition child are more prone for hypokalemia. So we will take care of hypokalemia. We should start insulin at lower doses. We start with normal fluid boluses as we give in DKA patients. The duration could be from 48 to 72 hours depending on child conditions. The insulin should be started at 0.05 unit per kg per hour because the child is more prone for hypokalemia. And we should look for hypokalemia signs as lab reports, as well as we could do ECG if required.
So very well concisely explained, sir. Thank you. Next, we have a 3-year-old boy with severe DKA, was being managed with an insulin and fluids for 6 hours, has a pH of 6.9, bicarb of 5 millimoles and ketone of 6.4 at presentation to our setup, and at presentation has potassium of 2.8 millimoles. So my question is to Chetan sir, what could have been done differently in this child, or how do we manage hypokalemia in the setting of DKA?
Yes. So we are lucky that we have initial potassium. Otherwise, usually it takes 1 to 2 hours for the report of potassium to come. So as discussed in the lecture as well, if your potassium is low, say if it is less than 3.3, then you should add potassium lower dose 20 millimoles per liter in the resuscitation fluid as well, because whenever we start insulin, we tend to give further hypokalemia. So I would like to add potassium in resuscitation fluid as well, followed by the full 40 millimole per liter in normal maintenance fluid.
So So the most important thing is that if your potassium is low, especially look for potassium before starting insulin. If your potassium is low, you may delay starting your insulin infusion, give potassium in the bolus fluid, and that is how we'll proceed. Next is a 10-year-old girl, blood sugar of 540, again metabolic acidosis and ketosis. So, Anisha ma'am, my question is to you. How do we go about in managing this case? What are the initial steps we will take in deciding the fluid or insulin doses?
Okay, so we can have the back slide, no issues. So this is a 10-year-old girl. Her pH is 6.9 and the bicarb is, there's a base deficit of -18 and the blood sugar is 540. So this is, we have no doubt this is typical DKA. Now we want to classify the DKA. So it is classified into 3 categories on the basis of bicarb and the pH. So mild category, the pH is 7.2 to 7.3, bicarb is 10 to 18. Then in the moderate category, the pH is 7.1 to 7.2 with the bicarb of 5 to 10 millimole per liter. And the severe category, the pH is less than 7.1 and the bicarb is less than 5. So the latest change in the guidelines is the bicarb, when we classify, initially we used to classify less than 15, now we classify less than 18. So the mild category is bicarb between the range of 10 to 18 millimole per liter. So by this definition, our patient falls into the category of severe DKA. Now the second question is, where do I want to manage my child? In the emergency ward or in the ICU? So ideally this child should be managed in ICU because the child has various criteria fulfilling for the risk factors of cerebral edema. Then the third question is, once you have transported the child to the ICU, how will you start the management? So initially you have to give the fluid management of the first hour, second you have to give the subsequent fluid management, and third is the insulin therapy. So the initial fluid within the first hour, as initially talked in the previous lecture, you give 10 to 20 ml per kg over 30 to 60 minutes. So we start at the lower levels only, so 10 ml per kg if you want to give to this child. So the weight is 30 kg, you give about 300 to 600 ml over half to 1 hour. Now coming to the subsequent fluid. So the initial bolus, what type of fluid we are going to use? Normal saline we are going to use in this patient. So the subsequent fluid requires the sum of the deficit plus the maintenance. So the deficit as mentioned is 10% dehydration. So it comes out to be 100 ml per kg into 30 kg. That comes out to be 3000 ml. So the maintenance fluid for the 48 hours will come out to be 3400 ml using the Holliday-Sidar formula. So the total comes out to be 6400 ml, which we have to give over 48 hours. We will subtract the initial fluid which we gave. For example, we gave 20 ml per kg, that is 600. So when we subtract that, it comes out to be 5800. So that 5800 fluid has to be evenly given over 48 hours. So the rate comes out to be about 120 ml per kg per hour. So which fluid we have to use? We again have to start with a normal saline 0.9%. We may also use 0.45 in certain situations. Now, when will you start insulin? After the initiation of the fluid therapy, once 1 to 2 hours have gone, then we start the insulin therapy. So what range you are going to start? We have a choice of 0.05 to 0.1 international unit per kg per hour. As previously also highlighted, 0.5 is a preferred choice because it leads to lesser complications of hypoglycemia, cerebral edema, hypokalemia. But there are certain specific exceptions also, like severe DKA, or we are dealing with an adolescent. Then we start with 0.1. So in this scenario, we will start with 0.1 international unit per kg per hour of insulin therapy. It has to be given as an infusion. Then frequently you have to monitor the child, the vitals and the sugar levels along with repeated ABGs.
Thank you so much, ma'am. So at 4 hours, the blood sugar persisted to be high and the acidosis persisted. So my question is for Dr. Lokesh. What could have been going wrong in this child leading to persistence of hyperglycemia and acidosis?
If we have given bolus and we have started insulin, it should start falling. If it is not falling expectedly, then what we need to check, we need to check from insulin vial what concentration it is, how it was made, like how much is the dilution. Is it appropriately, like we had planned that it should be 50 IU in 50 ml, maybe it was given 25 IU in 50 ml, so that we need to check. Rate of the insulin, what we need to check, that was it as we intended, and we need to check that it was primed. Many times, like experienced unit sisters know all these things. Most of the time, we do not need to check, but some new staff is there. Then we need to check that when we prepare this preparation, we need to flush the whole tubing with this preparation. It should come out from the end of the tube. Then only we need to start on the IV connection. So insulin, like insulin get attached to the plastic tubings. So it should get primed with insulin before starting. And then we need to check that after that we need to check that if it is falling or not. After all these parameters. Like I had one practical experience during my fellowship that one new staff was there and fluid and insulin was going on. I was on duty and he didn't change the tri-way cannula. So insulin was not going for 2-3 hours. And like child was passing urine, sugar was rising. I was convinced that insulin not going, but I couldn't figure it out. And I sat at the bedside. I checked everything from insulin vial, tubing, everything. Then I found that the tri-way cannula was not in the right direction. So that was that was due to inexperienced staff only. Like this may happen everywhere. So we need to check everything from starting point to end point. What is missing? Then we usually find all the things. And once I found that cannula was out, like everything was right, sugar started falling, and then suddenly after
Yes, so the often reason for poor insulin delivery or no delivery are mechanical causes. Either your cannula is out, and therefore Chetan sir very well pointed out that you should preferably have 2 separate cannula for your insulin and fluid so that these things occur less. They become rarer.
And another thing sometimes happens, when patient comes to us, in glucometer it will show high, HI. So we do not know how much is the sugar, and for hours it will be showing high because we do not know exact lab value. In that case, we should send the sample to lab. It may be 900 and it may be falling to 700 or 600 or 500, but in glucometer after 550 it will show HI only. So it is falling, but we are not knowing that it is falling. In that case, we can use lab value, or sometimes blood gas values also can be taken if it is reliably calibrated.
Thank you, sir. So, moving on at 8 hours, the blood sugar has come down and your acidosis is persisting. So, my question is for Neeraj, sir. Do you think at this point of time it would be wise to start tapering insulin doses so that the child does not go into hypoglycemia?
The blood sugar of the patient is falling and we expect that it should fall. But you should actually continue insulin and we should add dextrose depending on the level of blood sugar. In this, as the blood sugar is less than 200 milligram per deciliter, so we should add 10% dextrose. In 200 to 300 milligram per deciliter, we should add 5% dextrose. So we should continue insulin at the same rate and we should add additional dextrose in this patient.
Yes, thank you, sir. So an important point that comes out is your hyperglycemia starts resolving first. It is not an indication for stopping or reducing your insulin therapy. You will continue and you will add dextrose to take care of your sugar requirements. Moving on, the blood sugar is at 220 milligrams per deciliter. Acidosis is persistent. Now your potassium is falling down to 2.6. So again, Chetan sir, management of hypokalemia in this situation.
So now we see the acidosis part is improving as we see the base excess is increasing, but this full dose of insulin is causing hypokalemia. So definitely hypokalemia is more dangerous as compared to the resolution of acidosis. So we have two options. Either we can stop insulin for half an hour, we add extra potassium because peripheral line can bear up to 60 millimoles per liter, or maybe we can decrease the insulin till potassium comes above 3.5.
And what could have prevented occurrence of this hypokalemia? Doing what differently in the fluid management?
Yes, addition of the potassium in each and every fluid. So many times it happens that whenever we change from NS to DNS, we might forget the adding potassium into the DNS or maybe say 10% fluid. So definitely these all things should be in a protocol to prevent hypokalemia.
Thank you, sir. So at 14 hours now, the child has become comatose. A question for Arisha ma'am. how do we manage the case at this point of time?
So here I would like to highlight the importance of monitoring in a child with DKA. So while monitoring him, you have to look at the basic vital signs, the heart rate, respiratory rate, blood pressure, the dehydration status, along with the neurological signs are very important, like the sensorium, and certain important signs like headache, new onset headache, drowsiness, vomiting, which is persistent. Along with that, the abnormal pupillary reflexes and unequal pupils. So all these signs point towards cerebral edema. Like in our case, the child has become comatose. So there is a drop in the sensorium. So what we are dealing with increased intracranial pressure due to underlying cerebral edema, and which is likely due to the sudden osmotic shift which has occurred. Now, how do we want to manage this child? As any case of raised ICP, we have to do the basic things. We have to elevate the head end, and the most important is mannitol. And the important message is that for every patient of DK who has a risk factor for cerebral edema, mannitol should be kept bedside. So whenever you find that any of these neurological status signs of worsening are present in the child, immediately administer mannitol at the rate of 0.5 to 1 gram per kg. You don't have to wait for neurological imaging, that once I get an imaging, I may get the cause and then I will treat. You treat, and later on you may go ahead with the neuroimaging to find out any other cause of deterioration, like thrombosis or hemorrhage. Now the second thing, once the child develops this state of cerebral edema, you have to decrease your fluid maintenance rate to 1/3 of what you were giving initially.
Thank you, ma'am. So now at 20 hours, the blood sugar is 190 or acidosis is persisting. So my question is for Neeraj sir. What do we evaluate to understand the reason for this persistent acidosis, and how do we manage such cases?
So we should see whether the patient is improving or not. If there is persistent metabolic acidosis, but the patient is improving, most probably the cause may be hyperchloremic acidosis. So we should look for either the ketones level, if we have available, we could do ketones levels, or we could look for anion gap. If the anion gap is closing, then probably this is the case of hyperchloremic metabolic acidosis. Or if we could do ketones level, if the ketones level is more than 2, then it is probably ketoacidosis. Or if the chloride, then we should look for chloride load. If the chloride load is below 32, it is probably due to lactic acidosis. If it is above 32, it is probably due to hyperchloremic acidosis. So hyperchloremic acidosis is basically a benign condition, and even though the patient is having persistent metabolic acidosis, the patient can be subject to oral.
Thank you, sir. So again, hypochloremic acidosis usually does not require any additional treatment or intervention. At 28 hours now, the blood sugar is 170, base excess is -4, the child is conscious. So my question is for Lokesh sir. How do we, is this the right time to transition the child to subcutaneous insulin?
Right. Yes, it is the right time now. Child is conscious now. Acidosis is resolved, sugars are controlled, so this is the right time. We can switch over.
So what happened with this child was that the child was allowed orally in the morning, started on regular insulin units per kg subcutaneously, and fluid and insulin was abruptly stopped. However, post-meal, the sugars rose up to 560 milligrams per deciliter. So what could have we done differently in this child?
Yes, what should we have done rather? So this is rebound hyperglycemia. This is because DK is absolute insulin deficiency state. So there should be insulin on board always in our body. So we were giving IV infusion. So IV infusion is like it has half-life of few minutes only. As soon as we stop it, it will vanish from the blood. So there should be onboarding of insulin before which we allow meals. And there are two things we can do. Like earlier, what we used to do, we were trained on that only, that we should give subcutaneous insulin 1 hour before switching off the insulin infusion. So we will give subcutaneous insulin, and after 1 hour we will stop, and then we can give meals. So there will be insulin onboarding by subcutaneous. Subcutaneous will take some time, and insulin will be in blood by IV. Now what we do, and like most society also, they ask that more simpler way, more better way, that we can switch to the long-acting insulin night before. We are planning to stop insulin next morning, then previous night we will give long-acting insulin, whatever patient was on. Like if patient is on glargine, we will give glargine in the night, and in the morning then we will, and like IV infusion we can slowly, according to sugar levels, we can slowly come down in the IV infusion, and then in the morning we will give rapid acting or regular insulin, and then we will give meal. So that will have lesser rebound chances. So these are the two things we can go ahead.
Thank you, sir. So again, this child had normal ketone blood gas and normal sensorium, willing to take orally. So these are the indications for switching to subcute insulin. As sir pointed out very well, a dose of long-acting insulin giving a night prior to switching would have significantly helped in this jump in sugar, and stopping insulin infusion after 30 to 60 minutes would have allowed a better control. So post DK, this child was put on sliding scale. Every 4-hourly blood sugar was being monitored, and based on that sugar value, the child was being given doses of insulin, and this resulted in fluctuating sugars. So my question is for Chetan sir, do we recommend sliding scale of insulin for children?
So now we know very well the physiology that in sliding scale we just inject the insulin according to the blood sugars, and we are not considering the meal and all. But the physiology says whenever we eat a meal we need insulin. So ideally we should be now switching to basal bolus regimen that is more physiological, in which we give boluses before every major meal, and along with that we give long acting insulin, glargine or other insulins to reduce the hepatic glycogenolysis. So ideally the patient should be switched to basal bolus regimen, not the sliding scale.
Thank you so much, sir. So again, the dose of the insulin post DK should be around 2 to 2.5 units per kg per day. Just to summarize DK, so DK is a tight balance between the amount of fluids that you give. Too little fluid will lead to dehydration and clinical worsening. On the other hand, too much fluid will lead to cerebral edema and worsening of sensorium. Similarly, the other part of the balance is your insulin level. Too little insulin will lead to prolonged hospital stay, risk of hospital infections, and too much insulin will lead to hypokalemia, and it needs both of these things need to be balanced very gently in management of DKA. Thank you so much for the discussion.
Your insights, expertise and contributions have set the tone for this program, and we are all grateful for the opportunity to learn from you all. Let us give them all a thunderous round of applause. Now, I would request to just give the mementos to the speak. Dr. Chetan, sir. To the chairpersons for this session, Professor Singh sir. Professor K.K. Yadav sir. To the panelist, Dr. Arisha ma'am. And Dr. Neeraj sir. Dr. Lokesh sir. Now for this next session of hypoglycemia, with great joy and enthusiasm, I would like to welcome on stage Dr. Anurag Bajpayee sir. Sir is the consultant and leading the Department of Pediatric Endocrinology at Regency and the Director for Medi Classes. So please sir. Thank you sir.
Quality record is good.
For this session, the chairpersons would be Professor S.N. Singh sir and Dr. Chetan sir. Sir, kindly introduce the speaker.
So this session is on hypoglycemia. So the moderator will be Dr. Anurag Vajpayee, and he will give overview about the topic. And you all know, already introduced Dr. Anurag Vajpayee. He is a renowned pediatric endocrinologist in northern India, and he is running a practical pediatric endocrine course also. So he is well renowned in this field. The panelists will be Dr. Salini Tripathi, Dr. Lokesh, Dr. Namita Mishra, and the case will be presented by Dr. Sandeep. Okay. So over to Dr. Anurag.
Thanks a lot, sir, and thanks Dr. Arpita for organizing this event, the 4th Practical Pediatric Endocrine Symposium, along with ma'am, Dr. Mala, who is the HOD, Professor Singh, and this is a pleasure to be again here. Last year we had a very successful event, and this again is continuing here. So the overall initiative that we started in terms of pediatric endocrinology started with a lot of workshops because of lack of awareness in terms of pediatric endocrinology. So over the year we have conducted a number of programs. So this is the 14th pediatric course which are organizing across the country. We also conduct advanced courses in which we try to cover more advanced issues in terms of pediatric endocrinology, and a lot of other online programs which are there in terms of that. So all of you can go and have a look at our website learning.growsociety.in, which has got a lot of informative courses as well as resources in terms of pediatric endocrinology. A lot of things that we are talking here are already available on YouTube. So maybe you can focus on the discussion here, and then maybe you can go back and revise it over the freely available on YouTube. We have developed a mobile application which guides in terms of evaluation and management of pediatric endocrine disorders in a unique fashion. And if you just look at the DK, we discussed a lot about DK algorithms. If you just go through our app, it will just based upon the inputs that you give in terms of the age, in terms of the pH, bicarbonate, CO2, it will tell you how much fluid is to be given, how fast, how to evaluate, monitor and management in that perspective. We are coming up with a new tool which will help us in terms of evaluating growth in the form of bone age assisted interpretation of growth, wherein you just put in data in terms of the individual, and based upon that data you will get outputs in terms of real life evaluation and guidance from that perspective. There are publications also which are available. All of you can go have a look at that in that perspective. So we have got the panelists who are already there. And now when we talk about hypoglycemia, we need to know that glucose is very important source of energy for various parts of the body. The level in the glucose in the blood depends upon various organs, but the most important organ is the liver, in which we are exchanging the glucose with the liver. We also have kidneys which are going to produce the glucose from new resources, which is gluconeogenesis, and of course the fat will produce an alternate source of energy, which is ketones. So everybody who is hypoglycemic should produce ketones. If you do not have ketones, there is problem either in the ketone synthesis or there is too much insulin in that perspective. Now there are two major hormones which are controlling from the pancreas. One is the insulin, which is causing hypoglycemia, and glucagon, which is causing hyperglycemia. From adrenal, got cortisol and epinephrine, which are increasing the amount of glucose, and we have got growth hormone. So there is one hormone which is causing hypoglycemia. There are 4 hormones which are causing hyperglycemia. So a single hormone deficiency is extremely unlikely to cause a hypoglycemia. If you have hypoglycemia, it will be a multiple pituitary hormone deficiency from that perspective. So if you have a scenario in which there is too much insulin coming from the body, now we discussed in the last class, if insulin is less, you have ketosis. If you have too much insulin, you will have no ketosis. So this will be a non-ketotic scenario. Second, whatever glucose you give is being taken up because of high insulin, so your glucose requirement will be very high. That will be like 12 milligram per kilogram per minute. So non-ketotic, high GIR, direct indication towards hyperinsulinism. If you have a problem of cortisol deficiency, that will typically present to you with ketotic hypoglycemia, and there you will also have hyponatremia because cortisol plays an important role in sodium regulation. So we are trying to build the approach based upon this pathophysiology. If you have a problem in the storage, so your liver cannot store the glucose and doesn't supply you when you need it, the problem will happen a bit later. Because if you are feeding every 2 to 4 hours, you will have enough glucose to avoid hypoglycemia. If you are getting a lot of money as part of your earnings, then you don't need to go to the bank. But if you are not eating every 2 to 4 hours, then you would rely on the bank, which is the liver. So this will happen when the gap between meals is typically around 6 hours or more. So glycogen storage diseases will present typically around 6 months and beyond, and not in the neonatal period. The gluconeogenic defect will be active when you have a gap of more than 12 hours. So they will present typically after 1 year of age. So year of onset is also a good clue in terms of where your problem lies from that perspective. If of course you have a problem in terms of fructose problems or gluconeogenic defects, you will have a much later onset, and there will also be lactic acidosis, as I said, from that perspective. Very importantly, if you have a multiple pituitary hormone deficiency, that only will cause hypoglycemia. Very rarely GHD can cause. So if you have multiple pituitary hormone deficiency, there will be other features like micropenis, cleft lip, cleft palate. You will have other features which you can identify from that regard, and that becomes important. Now, fatty acid oxidation defect is a rare form of hypoglycemia. Typically this is during intercurrent illness. So you have a child who is absolutely normal, and suddenly with illness he requires a lot of metabolism, toxic substances accumulate, liver fails, and you will have what is known as race syndrome like picture. That will be the typical scenario in that regards. So hypoglycemia can theoretically be because of decreased production, in which if you give physiological glucose infusion of around 6 milligram per kg per minute, that will be fine, or increased utilization where your requirement will be much higher, around 6 to 12 milligram per kg per minute. Decreased production can be a problem of substrat, in that you don't have that much glycogen in the body. So if you are born premature or you are small for gestational age, that could be a cause. Or it could be a problem that you have got your bank balance but your ATM card is not working, or demonetization has happened, you cannot take out the money out there. So there could be a problem of either the hormones involved in getting the money out, or you have a problem in terms of the overall liver function or storage. So if you have an endocrine cause, you will have micropenis and midline defects which are there. If you have a metabolic defects, typically you will have other manifestation. Galactosemia is a unique disorder that typically is associated with inhibition of multiple glucose pathways because of accumulation of toxins. It typically happens between 2 to 3 weeks. You will have a neonate who will present to you with the abdominal symptoms, with hepatomegaly, cataract, hypoglycemia, E. coli sepsis. 3 weeks of life, that is a typical presentation of hypoglycemia, and cataract will be a manifestation. Increased utilization can be because of any illness, but the most common cause is hyperinsulinism. The most common persistent cause of hypoglycemia is hyperinsulinism, so think about that very likely. This hyperinsulinism will be non-ketotic. It may be transient because of maternal diabetes, the most common cause, or drugs in mother like beta blockers which are there. Typically this will resolve by 1 to 2 weeks. We are identifying a lot of prolonged hypoglycemia because of insulin excess in the setting of hypoxia. And that is something which we'll discuss about. Dr. Shalini was also discussing that this is something which will last up to 6 to 8 weeks. Identifying this form is important. And then finally, wherein your button for insulin secretion is permanently pressed, you are continuously producing insulin. So these will be the potassium channel defects. These babies will usually be large, macrosomic, hairy pinna, and other phenomena will be there from that perspective. So this will require a lifelong treatment. Now very importantly, if you have a child with hypoglycemia, you correct the hypoglycemia, but before you correct it, take some critical samples. Because unless you assess the metabolism during hypoglycemia, you would not be able to reach a particular diagnosis. So anybody who is hypoglycemic should have zero insulin. Any detectable insulin during hypoglycemia is significant. Anybody who is hypoglycemic should have ketones. If your ketones are below 2, that is significant. That is either a ketogenic problem, fatty acid oxidation defect, hyperinsulinism, or galactosemia may be the cause in that perspective. You should have a cortisol level of at least above 500 and ideally above 550. So a normal cortisol and a normal growth hormone during hypoglycemia is not normal. They should be high. This indicates deficiency, and that is a very, very important from that regards. And you should not be producing lactate in that regards. So if you have detectable insulin, this becomes hyperinsulinism. Low ketones becomes hyperinsulinism, fatty acid oxidation defects, or galactosemia. If you have high lactate, this is glycogen storage disease or gluconeogenic defect. If you have lower or normal levels of growth hormone and cortisol, this is multiple pituitary hormone deficiency, and these things will tell you the diagnosis. Now remember, glucometers are mainly made for looking at glucose level in diabetes patients. So they are not having a good coefficient of variation at low levels. So as we were discussing, whenever you have a low value, you should always confirm with a lab value, because that is something which is very, very important. If somebody, however, sends to the lab and the lab is not processing it, your glucose will become falsely low. We often see that some collection centers collect and then you will see glucose is 56. This is unreliable because every hour 10 milligram per dl fall in glucose will happen from that perspective. And very importantly, if somebody has polycythemia, you have falsely low level of blood glucose because RBCs are eating up that glucose from that perspective. Now, if we just look at the various classification, the single most important investigation in an infant, in a child, or even an adult with hypoglycemia is the ketone. You should have ketones. If there are no ketones, it is high insulin, fatty acid oxidation defect, or galactosemia. I think that will be the first thing to look at. Second will be lactate. If your lactate is high, this is glycogen storage disease type 1, or you can have a fructose 1,6 bisphosphatase. Acidosis again is a good marker, and of course you should have undetectable insulin. Any detectable insulin means hyperinsulinism. So just by using some few investigations, you would know what to go forward, and glucagon test is more for specialization, so we are not going in that perspective. But I would say ketone, lactic acid will give you your diagnosis in most cases, and this is what we are coming up in terms of the approach to that. So any child with hypoglycemia, ketones if they are low or absent. Now less than 2 is also significant, less than 0.6 is definitely hypoketotic. This means only 3 possibilities. So do a urinary reducing substance. If the reducing substance is positive, that is galactosemia or fructose intolerance. If reducing substance is negative and insulin is undetectable, this is fatty acid oxidation defect. If insulin is detectable, this is hyperinsulinism. On the other hand, if your ketone is high, now you have got a lot of conditions to look at. Next step is lactate level. If your lactate is high, this is GSD or gluconeogenic defect. If your lactate is normal, now your diagnosis is a bit narrow.
baby had lethargy and the sugar was found to be 36. So, Dr. Lokesh, sir, considering the age of the patient, what is the most likely possibility and how will you go ahead?
So now 6 months old child, so we should start thinking about causes also. Is there any organomegaly? Yeah, we can see that if it is the ketones are positive, so this is not hyperinsulinemic or FAO defects, fatty oxidation defects. Lactate is positive. So now ketone and lactate, that means we are dealing with GSD. GSD1 should be the first diagnosis in this scenario. Hepatomegaly is also there. So this is GSD1 only, one Gregg disease, where glycogenolysis doesn't happen and lactate acid produced during that process. So this is most likely glycogen storage disease type 1.
So, thank you very much, sir. Correctly pointed out. Considering the age of this patient, so after 6 months of age, we should always consider GSD. And in GSD, there will be ketosis along with lactic acidosis. The next case, 3 weeks old boy, there was failure to thrive, sugar was found to be low. GR was 6, there was hepatomegaly. Dr. Shalini ma'am.
Whole scenario goes in favor of and reducing substance was positive
Yes,
in
ma'am.
this patient. So galactosemia is the most likely cause.
Yes, ma'am.
Yeah.
Thank you very much, ma'am. Ma'am.
When do you think we should go in to get genetic analysis? Because as Dr. Lokesh said, the transient causes could go on presenting till around 12 months of age also. So when
I think now the guidelines are very, very clear. The first, when you have hyperinsulinism, you should look for diazoxide responsiveness. If somebody is diazoxide responsive, then getting a genetics is not something which is going to help you out much. If they are diazoxide responsive, maybe get an ammonia level done. If ammonia is high, this could be one specific genetic disorder, which is a hyperammonemia syndrome. If there is diazoxide unresponsiveness, so if you are giving 15-20 milligram per kg per day of diazoxide and the child is not responding, then you have a role of immediate genetics. And what we suggest is that you do for both parents as well as for the child. If you have a potassium ATP channel defect coming from the father, this has been shown to be more likely to be a focal form of hyperinsulinism. Then you can go ahead with PET and everything. If there is a autosomal recessive coming from both genes are affected or it's coming from the mother, it's more likely to be a permanent. So I think the key is genetics is clearly indicated in diazoxide unresponsive individuals. And prolonged form, you don't need to do genetics. They will respond and then usually 6 to 8 weeks, sometimes they may be even prolonged, but don't worry about that. Mild doses of diazoxide doesn't matter, you can continue for a longer time. Yeah.
Thank you very much, sir. The key message here is in the neonatal period, if there is hepatomegaly, we should always suspect galactosemia. And in galactosemia, there will be no ketosis and there will be reducing substances will be positive. So next question, 1-year-old girl, she was not waking up in the morning, the blood sugar was found to be low, there was no hepatomegaly. So Dr. Namita ma'am, what will be your approach?
So basically now we are dealing with an infant who is having hypoglycemia. Now next in this case will be, again the first step is always will be seeing the ketones. In this case the ketones was positive, okay, so ketone levels were 3.5. So now once we get positive ketones, next step will be to do the lactate levels. And in this case the lactate levels were normal. Now if it is high, then we will think about glycogen storage disorder type 1. However, if it is normal, the next step will be to see whether organomegaly is present or not. In this case, organomegaly was not present. If organomegaly is present, then you have to think about glycogen storage disorders, other forms. If it is absent, organomegaly is not there, then we have to think about the hormone deficiency, endocrine deficiency. So in this case, we can see that growth hormone levels and cortisol levels were higher. That is, response was there to hypoglycemia. The counter-regulatory hormones were responding. So definitely the hormone deficiency is not there. There is no organomegaly, ketone levels are positive and lactate is normal. So our diagnosis in this case will be accelerated starvation. Right? So in this, sometimes in these children, but sir has already pointed that accelerated starvation is a diagnosis of exclusion. Whenever we are getting the child in this age group with hypoglycemia, we must rule out hormone deficiencies. We have to rule out the endocrine deficiency, only then we will call it as accelerated starvations. So for intervention, we need not give any drugs, we just need to advise for the proper feeding of the child.
Thank you very much, ma'am. So the key message, when there is ketosis with normal lactate, we should suspect ketotic hypoglycemia, and we should always exclude the growth hormone and cortisol deficiency before labeling the patient as accelerated starvation.
One important thing is that sir always say that whenever we have the normal levels, that also means a deficiency at this point of time. We should have high hormones at the time of hypoglycemia.
For the level of hypoglycemia, the cortisol should be more than 550 and the growth hormone should be more than 5.
And another thing I would like to add is that since we have talked both about non-ketotic and ketotic hypoglycemia, and residents are here, so you should know that non-ketotic hypoglycemia is much more dangerous than ketotic hypoglycemia. So we have to be very careful because brain is dependent upon ketones if sugars are not there. And if ketones are also not there, then it will directly cause the neurological symptoms. So be very cautious about a non-ketotic hypoglycemia.
Very correctly brought it out, ma'am. So this is a 2-year-old boy. Maybe he had failure to thrive. There was vomiting, lethargy, and the sugar was found to be low. Ketones were positive, 3.2, lactate was 1, and the patient was labeled as accelerated starvation. So Dr. Lokesh sir, what is your opinion?
Yes, so we should examine the child. Like lactate is normal, but still we should look for organomegaly, and we should rule out other hormone deficiency before labeling it accelerated starvation, because accelerated starvation is common, but we do not have any specific point to diagnose it. This is diagnosis of exclusion. So if we don't find anything and we find ketones, and usually they have a history that child had missed a meal, like last night थोड़ा बीमार था, बच्चे ने खाना जल्दी खा लिया था, नहीं खाया था, बहुत कम खाया था, early morning he had hypoglycemia. This is very, very typical history we get in toddlerhood, and then only we get. So we should exclude other hormone deficiency first.
In this case, the patient was on examination was found to have pigmentation. So the cortisol level was low. For the level of hypoglycemia, there was hyponatremia also.
So it should be adrenal insufficiency.
Sir, thank you very much, sir. So
and alacremia also. So
this
now
patient had
cause of adrenal deficiency, alacremia, and so this is AAA syndrome, where alacremia it is present in almost all cases. Then achalasia it comes in early childhood, and cortisol deficiency, and sometimes autonomic dysfunction and amyotrophy. Now they say AAA, then quadruple A, and 5A also they say sometimes in some articles. So this is cause of adrenal insufficiency in this case, but cause of hypoglycemia is adrenal insufficiency.
So thank you very much, sir. The key message: ketotic hypoglycemia is not always accelerated starvation. We should always rule out cortisol deficiency before labeling the patient as accelerated starvation. Thank you very much, sir. Thank you, sir.
Now we would like to present mementos to the speaker, Dr. Anurag sir. Chairpersons, Dr. S.N. Singh sir. And Dr. K.K. Chetan sir. And to the panelist, Professor Shalini ma'am. Dr. Lokesh, sir. To Dr. Namita ma'am. Now we will be starting with the formal inauguration. Before inauguration, I would request all respected faculty members to come on the dais for a group photograph. The capacity to learn is a gift, the ability to learn is a skill, and the willingness to learn is a choice. I once again take the pleasure to welcome you all to the 14th Practical Pediatric Endocrinology course being organized under the auspices of Department of Pediatrics, KGMU, Lucknow, Grow Society and Medi Classes. The modules in this course include a combination of didactic lectures, case-based discussion, and practical exercises to ensure active participation of the delegates, and it aims to cover all key areas of pediatric endocrinology, including glucose, calcium, electrolyte, growth, thyroid disorders, and puberty. The module was first implemented in Kanpur in 2012 by Dr. Anurag Bajpayee, is now being implemented in different parts of the country. I encourage you all to actively participate in all the sessions and make the most of this unique opportunity to enhance your knowledge and skills. I wish you all a very productive and enjoyable learning experience. It is believed that the light of the lamp dispels darkness, illuminating the path ahead and paving the way for success and prosperity. As we light the lamp, let us take a moment to reflect on the importance of knowledge and wisdom in our lives. Let us remember the great scholars, thinkers, and leaders who have illuminated our paths and inspired us to be our best selves. I would now like to request Honorable HOD Ma'am, Singh Sir, Anurag Sir, Chandrakanta Ma'am to please light the lamp. Our respected HOD ma'am is a clinician with unmatchable proficiency, a teacher with extraordinary expertise in her subject who goes out of her ways to help her students, and a benevolent and human person who will leave no stones unturned to help her patients. Throughout her distinguished career, our Honorable HOD ma'am has demonstrated an unwavering commitment to excellence and a tireless dedication in advancing the course of education. Her charismatic personality, humility, and cordial nature is an inspiration for all of us in the department. It is my pleasure to welcome our esteemed Head of Department, Professor Mala Kumar ma'am, to deliver the welcome address. Please, ma'am.
Thank you, Anshika. Anshika. I'm sorry I get mixed up with names, you know. Anshika, Akshita, Anamika, they all, so that's my problem. So I welcome everybody who's made such efforts to be part of this CME that has been organized by Arpita, very diligently, working very hard at it for the last, I don't know how many months. And a special welcome to Dr. Bajpayee, Dr. Dave, and all the experts who've gathered here to be with us today. Dr. Lokesh, we are really privileged to have you all. Endocrinology is something that we do in bursts and spurts. So it's not like something that we are doing every day. So we tend to read more about it when we have a patient and we get stuck. And so we tend to forget. I'm talking about myself primarily. We tend to forget how to work up patients. So I think what is important is to get exposed. Like today we've got nicely, properly exposed to things so that next time when we see a patient, at least we know that where to think, what we have to read up, how to approach. It's difficult to be experts like Dr. Bajpayee, Dr. Dave, Dr. Lokesh. But definitely what the mind doesn't know, the eyes won't see. So please enjoy the sessions. And what is amazing about these sessions is how practical they are. I mean, things that we are doing every day, in and out, in the PICU, struggling with DKA patients, not understanding, ab kya ho gaya, ketone badhe hi hua hai, kam kyun nahi ho raha, why is the acidosis not improving, why has the patient become lethargic, we read that shock to hota nahi DKA mein, shock kyun ho raha hai. So at least they've shown us the way. So enjoy the session and have a great day. We are, I think, 1/3 into it and lots is still left. So thank you once again for being here and welcome all of you who've made such efforts to be here. Thank you so much.
Dr. Anurag Bajpayee, sir, we all know, is one of the key speakers for today's CME. He is currently associated with Regency Hospital as a consultant in endocrinology. Apart from being a renowned clinician, Anurag, sir, is also an exemplary teacher and an academician par excellence. Dr. Anurag, sir, has completed his MBBS and MD from AIIMS, New Delhi, and a fellowship in pediatric endocrinology from Australia. He is also the General Secretary of Growth and Obesity Task Force, Regional Coordinator, Disha Program for Increasing Awareness about Childhood Obesity, Founding Secretary of Celiac Society Kanpur, and a member writing committee for ISPE guidelines in type 1 diabetes mellitus management and childhood obesity. Throughout his career, our speaker has demonstrated a deep commitment to excellence and a passion for sharing their expertise with others. His dedication and commitment to helping others achieve their things in their areas. I would like to invite Dr. Anurag sir to put some lights on today's session.
Thanks a lot, and thanks ma'am, Professor Mala, Dr. Chandrakanta, Professor Singh, and the entire KGMU team, especially Dr. Arpita for inviting us to conduct this program, second time in Lucknow. So this is really a pleasure to be part here. Now, pediatric endocrinology is something which has been very close to me from very, very long time. Probably even my undergraduate days or something, I was more fascinated towards endocrinology and towards pediatric endocrinology. So even during the MD one, but when I came back, what I realized was that there were a lot of issues in terms of when the patients were coming to us, how they were being managed, and as we reported that DKA patients were coming to us with cerebral edema right at diagnosis. 20% of short stature are coming to us when their bones are fused. Precocious puberty in girls, 30% are coming when it's too late, when we can't do any intervention. So there were a lot of issues which were happening in terms of evaluation and management of these disorders. Now, a lot of people think that endocrinology is an expensive branch, the cost is high, and that is why things are not happening. But actually, when you look at any disorder, there are 3 A's which will tell you how things are going to happen. One is awareness, accessibility, and affordability. So if a child's parents don't know what is the right age for them to go to a pediatrician, if the pediatrician is not aware when should they evaluate, what tests to do in what order, and then things will happen. So the worst case which I saw was a case of who presented to me with short stature when the bones were already fused. And he had all the features of celiac disease. He had clubbing, he was very short, he had abdominal symptoms. And unfortunately, because of the anemia, he was not being evaluated for celiac. He was given blood transfusion, and that resulted in development of HIV. That was a shocking scenario, that the cost of blood transfusion is 6,000 rupees. TTG at that time was 600. So it's not an issue of affordability, it's an issue of awareness. So we started off with a lot of programs. So we started off with these practical courses. I remember around 13, 14 years ago, we started with the program. We conducted a lot of workshops. Then we realized how many workshops can you do over a extended period of time. It's not physically or financially or whatever way possible. So we started with our YouTube channel, then the online course, and then the resources have been developed. So all that we are talking here is already available freely on YouTube. You can have a look at it. In our website also, a lot of courses are available. So those approaches become important. Now, as ma'am was saying, that when we did these courses, what was happening is that time everybody understands, but what would happen later on? How do they really apply that in terms of clinical? So we realized that unless we have a point of care tool, so if you know everything, ketotic, hypoglycemia, non-ketotic, the patient is there, your mind becomes blank. You can't really use that. And if you open a book, you start the book and go from there, it will take pathophysiology and you're gone. So what we have developed is that we have developed mobile applications tools which are basically helping instantaneous diagnosis and evaluation. So if you have hypoglycemia, it will say what is your ketone levels. You will say 1.2, it will go to the hypoketotic one. Then it will ask about what is your insulin. So we have now developed, and the latest version is coming within the next week. It has got specific interpreters for hypocalcemia, hypercalcemia, electrolyte, glucose, DSD, so all the interpreters, and they have been validated. One of the interesting validation we did was on DSD interpreter. We compared the outputs with the outputs from a practicing pediatrician, pediatric trainee, pediatric endocrine trainee, and a pediatric endocrinologist. And what we realized was that there were so many errors happening at the level right from pediatrician to a pediatric endocrine trainee. So if you have a systematic algorithm which is fed into the mobile application, you will get a guidance in terms of evaluation and management. So this is the way forward, and ultimately my aim would be that we have got EMR and OPD tools in which whenever you just enter history and examination, everything gets analyzed, you get guided from there in terms of evaluation and management. We are working in that direction. So hopefully now, since the last 15, 20 years that we have been working, we are now finding a lot of good results. So we've got people who are working now across the country. So in our fellowship program, the online one, we've got around 100 fellows who are there from across the country. And people like Dr. Arpita has really taken up lead and developing the speciality there. So I think the most important part is to develop force multipliers, because one person cannot do everything. And if everyone gets aware, that is the aim. My message to the pediatricians and all the postgraduate trainees who are here is that endocrinology is not something which is very exotic. Every case that you see will have an endocrine issue. There will be issue of growth, there will be issue of puberty, calcium, glucose, electrolyte, everywhere endocrinology is there. So if you don't think of it, it's nowhere. But if you think of it, it's everywhere. That will be the message. So hopefully this workshop will open you up, prime you up in terms of picking up those disorders and manage them better. Thank you.
Thank you so much, sir. Now I would like to call Professor S.N. Singh, sir. Sir is a professor in the Department of Pediatrics, King George Medical University. Sir is dedicated in advancing pediatric medicine with passion and precision. He is a mentor shaping minds, balancing care and research, and in every patient and student, sir always leaves a lasting view by his wisdom. Sir, please.
Yeah, first of all, congratulations to Dr. Arpita and her team for organizing this CME practical pediatric endocrine course. Okay, so last year I remember again these all courses are actually very useful as name practical pediatrics. So you read from book a lot and you will forget. Okay, so he is highlighting the way the topics has been designed, the real case scenarios, and so that gives definitely a better learning. And just I was sitting with initial 2 topics, so that reminded me. The first topic was on DKA. So ये हमारे MBBS में एक full question आया था, diabetic coma, I remember. Diabetic coma, that was a full question, and external examiner Dr. Sarkar, उनका paper था. So we written whatever at that time, and दूसरा hypoglycemia पे, तो ये हमारे MD पे full question था, hypoglycemia, and Dr. B.C. Chaparwal, okay, so he used to be the vice chancellor at that time in the Indore University. So his paper was this, and luckily उस paper में मेरा सबसे अच्छा हुआ था, so he called me and he disclosed the things, and he also done international conference on magnesium. Okay, so can you imagine at that time magnesium पे international conference किया था. So basically this course is designed in such a way that I think everyone will get benefit from it, and we hope that the subsequent lecture will be further encourage you for this course. And Dr. Anurag said, okay, so even after this course, you can have always a look. If you have, he is having a lot of videos on YouTube, so you can have help from all these. So best of luck for the subsequent lectures. Thank you.
Thank you, sir. Now I would like to warmly welcome Professor Chandrakanta ma'am. Ma'am is a BA-Con in Pediatric Neurology, and with her expertise, young lives always thrive in harmony. Ma'am is inspiring us all with her lasting dedication, empathy. Ma'am, please.
So I congratulate Dr. Arpita and Dr. Anurag Vajpayee, sir, and I appreciate their effort. And they have organized such a wonderful workshop, and the modules are so interesting, so relevant. And as Dr. Anurag said, that we think that endocrinology is like the cases are not so much, and this I used to think also. But now when the Arpita is in my unit, I know so many cases coming, and she admits them for the workup. So the cases are everywhere actually. And in day-to-day practice, this electrolytes, hypoglycemia, all these things we experience, and we should be aware of all these things. So I think this course is really wonderful and well-organized course. And I welcome all the delegates to this workshop here, and all the best. Thank you.
Thank you, ma'am. Now I would like to invite Dr. Arpita ma'am to deliver the vote of thanks.
Respected Professor Malakumar ma'am, Dr. Anurag Vajpayee sir, the course coordinator for today's course, President Lab, Dr. Nirmala Joshi, Professor S.N. Singh Sir, Dr. Chandrakanta Ma'am, and Secretary Lab, Dr. Utkarsh Bansal, esteemed guests, colleagues, and all the participants. On behalf of the organizing committee, I extend my heartfelt gratitude to each one of you for attending this continued medical education event. It has been a privilege and an honor to host such a distinguished gathering of medical professionals from various fields and backgrounds. Firstly, I would like to express my deepest thanks to my head of the department, Professor Mala Kumar ma'am, for her unwavering support and guidance in leading me into this field of pediatric endocrinology. Without her encouragement, this program would not have been possible. I would also like to extend my sincere gratitude to Dr. Anurag Bajpayee sir, who has been an exceptional mentor and guide to me. Dr. Bajpayee is not only an outstanding teacher, as you have already seen, he is blessed with the ability to make complex concepts accessible. But he is also a humble and compassionate individual who constantly inspires those around him like me. His dedication to his students, his willingness to offer guidance at every step, and his genuine care for their professional and personal growth make him an invaluable mentor. I'm truly fortunate to have learned from him and continue to learn and benefit from his wisdom and encouragement. My sincere appreciation goes to all the keynote speakers who have generously shared their expertise and knowledge. Your insights as well as your ideas have enriched our understanding of the latest advancement in this field. I'm also deeply grateful to the moderators, chairperson, panelists, and presenters whose passion, dedication, and hard work have made this CME informative and engaging for the rest of the day also. I would like to extend my gratitude to our sponsors and exhibitors for their invaluable support and contributions, which have significantly contributed to the success of this event. Your partnership is truly appreciated. Lastly, I acknowledge the tireless efforts of the organizing committee, my residents, my staff, who have worked diligently to ensure the smooth execution of the CME. Your dedication and teamwork have been crucial in making this event possible. Once again, thank you all for your esteemed presence and active participation in the CME, and I hope you gain knowledge and insights throughout this day. Thank you so much.
Now, please join me in welcoming our next speaker. Dr. Arpita Bhriguvanshi, ma'am is an additional professor from King George Medical University at Department of Peadiatrics. And the next session is on calcium metabolism. And the chairpersons for this session are Professor Mala ma'am, Professor Chandrakanta ma'am, and Dr. Pragati Sisodia ma'am.
आपका पीपीटी
खुला एंड हेलो कैसे चलता है ओके पीछे कैसे जाता है ये बैक
Slide दिखा दो.
Good afternoon to everybody.
I want to introduce you, dear.
Okay.
Nobody knows who you are.
Yes.
वो वाला लगा दीजिए slide. So presenting Dr. Arpita Bhriguvanshi, who carries the torch for endocrinology from our department of KGMU. She has done her MBBS and MD from here, and then she did a fellowship in Cincinnati, and she is currently an additional junior grade professor, and she's in charge of the Pediatric Endocrinology Clinic. And she's got several publications and awards, and we welcome her today for this.
Thank you so much, ma'am.
And it's because of her that so many of our endocrine patients, through her linkages with experts, we've been able to help in a big way.
Thank you,
So
ma'am.
thank you.
Thank you, ma'am, for the kind introduction. So we've already discussed about DKA and hypoglycemia, and moving forward, I will be talking about calcium, which also we routinely encounter in our ICUs. So as we know, the calcium plays an important role in so many physiological processes in our body. Therefore, a basic understanding of the physiology is of paramount importance to detect, timely detect, as well as manage these conditions. We all know that calcium is mostly stored in the body, in the bones, to the tune of 99% as the non-exchangeable calcium hydroxyapatite crystals, and only 1% actually, which is in the outer cortex, is available for free exchange with the serum. This serum calcium is bound to albumin to the tune of 40%, and 10% is bound to other anions and phosphorus. And 50% is only available as ionic calcium to exert its effect. So therefore, we cannot rely on the total serum calcium, as it is not the true reflection of the body stores, because largely it is stored in the bones, as well as because it is largely affected by the protein status of the body. If there is hypoalbuminemia, there will be falsely low total calcium values and vice versa, which is not the case of ionic calcium. So we should, before proceeding to extensive workup for hypocalcemia or calcium disorder, we should take into account ionic calcium, which does not have any effect with the albumin levels. However, the ionic calcium is also not without any fallacies, because it is the bound calcium to the albumin is dependent on the acid-base status of the body. If there is alkalosis, there will be more anionic, there will be more anions like albumin, and there will be more binding to the albumin, leading to low ionic calcium levels. So that also we need to keep in mind while treating the patients of respiratory alkalosis as well as metabolic alkalosis. When we are giving soda bicarb to our patients of kidney failure, we have to be wary of hypocalcemia developing in these babies. So ionic calcium is low in alkalosis, both respiratory and metabolic alkalosis. Now, calcium is very tightly regulated by three major organs like intestine, bone, as well as the kidney, under the influence of the parathyroid hormone, calcitriol and calcitonin, which will lead to increased intestinal absorption, bone turnover, and renal calcium excretion. The acute regulation of calcium is majorly done by the bones, whereas the chronic regulation is done by the kidney as well as the intestine. And calcium is sensed through the calcium sensing receptor, which is in the proximal convoluted tubule, which will lead to decrease in the PTH and increase in the excretion of the calcium. So there is a tightly coordinated calcium hemostasis which is regulated by the body. When we talk about the symptoms of hypocalcemia, hypocalcemia presents with myriad of symptoms, basically presenting to us with symptoms of neuronal excitability in the form of jitteriness, in the neonatal age group spasm, or seizures in the older children. It may also present with cardiac failure due to decrease in the contractility of the heart, and cardiomyopathy. It may also present with intracranial calcification. So many of our patients of hypocalcemia have been detected on intracranial calcification and were on antiepileptics, and it was lying undetected. It may also present with headache and raised intracranial pressure symptoms, and also stridor and laryngospasm in some of the babies. Also, cataract is a infrequent presentation of hypocalcemia. Among the neonatal age group, screening should be routinely done in premature babies born before 37 weeks of gestation. As we know, because the maximum accrual of the calcium is happening in the third trimester. So these babies are at risk of hypocalcemia. We know that the nadir usually of the calcium is at around 24 to 48 hours. This nadir will be higher in premature baby as well as the very low birth weight baby below 1500 grams. If on a routine cardiac evaluation there is some cornotruncal defect, we should also evaluate for hypocalcemia as is seen in Dye-George syndrome. So Dye-George syndrome may have other phenotypes like absenthymic shadow and retrognathia and all. So whenever we encounter any of these things, we should be evaluating for calcium. Calcium assessment, any disorder of calcium, basic workup of calcium homeostasis is required. So first line investigation comprises of calcium, phosphorus, ALP, as well as the magnesium and creatinine levels. Only after these initial investigation, we should go for the second tier investigations, which includes the parathyroid hormone, vitamin D, and the calcitriol. So calcium sampling should be done in the morning, desirably in the fasting state. In newborn, you may do it anytime. The total serum calcium is not reliable. It has its own pitfall, as already discussed, because it may be falsely low in cases of hypoalbuminemia. In children with nephrotic syndrome or chronic liver disease, it may be falsely low, and we should rely on the ionic calcium levels to further evaluate such babies. There will be higher total serum calcium levels when there is hyperproteinemic states, which is not very common in the pediatric age group. However, if we do not have the facility of ionic calcium, we may just adjust with the level of the albumin. We know that for every 1 gram per liter decrease in the albumin, the serum total calcium decreases by about 0.8 milligram per deciliter. So we may use this calculation to adjust for the albumin levels of the child. Serum phosphorus is the most important investigations when we are evaluating hypocalcemia. Before proceeding for further workup, we have to look at the serum phosphorus level. It is also done desirably in the morning in the fasting state, because the carbohydrate content influences the serum phosphorus values. However, some caution should be done that it should not be a tourniquet sample or a squeeze sample, because phosphorus, as you all know, that it is an intracellular ion and it gets affected by the hemolysis which is happening, and there will be a falsely higher values of phosphorus. So care should be taken for a non-hemolyzed sample to work up further. We should follow the age-specific criteria for diagnosing conditions of hypocalcemia, because phosphorus is usually towards higher range in the neonatal or infancy, and it comes down to around 2 to 4.6 milligram per deciliter in the adult. So in neonates and infants, the cutoff is 8 milligram per deciliter, and it should not be labeled as high phosphorus levels. And we can convert milligram per deciliter values in millimoles per liter by using this equation. Now, the next investigation which we rely on is the parathyroid hormone. The extreme caution should be done while sending the sample, because it's a very short-lived and thermolabile hormone. It should be collected and transported in ice, or much better is to transport the child who needs the evaluation to the laboratory to get it done, because this is very important when we are making the diagnosis. The thing with parathyroid hormone is also that the single value of parathyroid hormone has no implications if not done in context with the serum calcium values. So what the random parathyroid hormone levels are of no value to us. It should always be interpreted with reference to the serum calcium levels correspondingly. So if the serum calcium levels are low, the normal body physiology will be to increase the PTH value. However, if there is hypocalcemia with hyperparathyroidism, with PTH being high, it is not able to increase the calcium levels further, we should be suspecting about pseudo-hypoparathyroidism and secondary hyperparathyroidism in such cases. In case of hypocalcemia with low PTH, the diagnosis is hypoparathyroidism. Even if this PTH is normal, it is abnormally normal, I mean it is not higher. What we expect is higher PTH. If it is normal also, we will make the diagnosis of hypoparathyroidism. So the PTH value has a contextual assessment. We should always be interpreting it in the light of the serum calcium values. I would come to this classification later. First, I will run you through the approach, a general approach for a hypocalcemic baby. Before going to the algorithm, what we have to make sure is that the baby does not have hypomagnesemia. Magnesium plays a very important role in calcium hemostasis because it releases the pre-manufactured PTH. It is responsible for the release as well as further action of PTH. So we have to rule out hypomagnesemia before working the baby or the child for hypocalcemia. We also should be looking at the albumin and the protein status of the baby and also the chelation effect, which affects the ionic calcium. So whenever the baby has been transfused with blood products recently, or there is hemolysis or such condition or tumor-lysis syndrome, it will also lead to hypocalcemia and ionic calcium will be low. Once we have ruled out those conditions, we have to follow this algorithm. The most important first step in this is getting a phosphorus done, keeping in mind all the precautions to estimate this phosphorus levels. It should be a non-hemolyzed samples, and then based upon whether it is low or normal, we will be thinking about vitamin D related disorders. If it is high, only two D visible. That one is the CKD and the other is the hypoparathyroidism or pseudo-hypoparathyroidism. So if the phosphorus is low or normal, the next investigation we need to do is the vitamin D. If the vitamin D levels are normal, we need to get the calcitriol done. So only in very less cases we will be going up till this stage and getting a calcitriol levels done. So calcitriol levels are basically to distinguish between VDDR1 where the levels will be low, and in VDDR2 the levels will be high. If the 25-hydroxy is low, we have the diagnosis of vitamin D deficiency, which is the most common cause of hypocalcemia in our setup. When the phosphorus is high, we need to do the creatinine first. That is the first investigation when the phosphorus is high, and we need to rule out CKD. If the creatinine is normal, we have to go for the PTH hormone assays. If it is low, we make a diagnosis of hypoparathyroidism. If it is high, then it is a case of pseudo-hypoparathyroidism. That is the PTH resistant state. The PTH is high, but it is not working due to the receptor problem. I would now like to call upon Dr. Alapan to carry forward the panel discussion. I would like to call upon the panelists for the calcium module, Dr. Nitin Pandey. He's alumnus of this institute, and he is my batchmate and a good friend. He's a pediatric endocrinologist and practicing in Lucknow. Dr. Dhwani, she is currently the fellow with Sir at Regency Kanpur, and I will be joining them in the panel discussion. And you have been introduced? So Dr. Alapan is the current fellow pursuing his fellowship in pediatric endocrinology with Sir at the Regency Hospital, Kanpur.
So good afternoon, everybody. I'll start with some cases of calcium disorders. The first case, a 4-month-old boy presented with nephrotic syndrome. His calcium level was 7.2. He is a complete asymptomatic child with features of nephrotic syndrome only. So I'd like to know, Arpita ma'am, would you like to recommend any investigations, any management in this child?
So I would like to know first that it is the total calcium value or the ionic calcium value?
This is a total calcium value that has been done.
As already been discussed, that total calcium value is dependent on the albumin status of the body, and nephrotic syndrome, we are losing the proteins. So it may be falsely low. So I would like to do the calcium levels, ionic calcium levels, to see whether there is true hypocalcemia present or not. Or I may adjust the total calcium values for the degree of hypoalbuminemia. So if after adjustment with the albumin level, what is the calcium?
So the calcium level is 8.8 after adjustment of the albumin. Albumin is low in this child.
Right, so we have a normal calcium level and there is no hypocalcemia in this child.
So as ma'am has rightly said that we should always look for the albumin level before jumping into anything else. Albumin is bound to the calcium around 40%. So the free calcium level is much more preferred in terms of judging the calcium level in that scenario. So in moving on to the next case, the case number 2, a 4-year-old girl presented with tetany and ionic calcium level was low, 3.1 milligram per dl. Here the phosphorus level was 8.4 and PTH was high. So considering this 8.4 phosphate and PTH, someone has diagnosed this case as a case of pseudo-hypoparathyroidism. Dr. Dhani, I would like to know whether you are agreeing with this diagnosis or not.
Often it is important to look at the child as a whole instead of just the investigations that you have. An important differential in a child with hypocalcemia and hyperphosphatemia, one needs to rule out CKD, that is, look at the serum creatinine levels here. Also, you look at the a long-standing vitamin D deficiency can also present with similar scenario, and that needs to be looked at before we jump to the diagnosis of PHP here.
So the creatinine level in this child is 2.4. And as ma'am has already discussed, before jumping into the any costly investigations like PTH, and we should always look for the basic investigations and always correlate clinically, like in chronic vitamin D deficiency can also lead to present a picture like PHP. So moving on to the next case, a 1-year-old boy presented with neonatal seizure with a low calcium level 5.4 and a phosphorus level of 6.1. His PTH was on the lower side, 11 picogram per ml. So he was admitted and given multiple boluses of calcium as well as IV calcium, but there was no improvement in there. So Dr. Nitin, what do you think, what is wrong in here?
So in this case, the patient is not responding to calcium. So we should think of magnesium also. And picture is, in the algorithm also, first we should rule out the magnesium deficiency, along with that albumin and phosphate load. So what was the magnesium level?
So the magnesium level in this child was low, 0.42.
That is low. Okay.
So this child was detected as a case of TRMP6 defect.
And this defect is actually absorption defect, in which we need a very high dose of magnesium. And this is lifelong defect, means the baby has to take magnesium lifelong. So magnesium we should consider in refractory hypocalcemia. Whenever we are giving calcium and the baby is not responding, then we should think of magnesium also.
Thank you, Nitin sir. Moving on to the next case, a 3-month-old girl child presented with seizure. Ionic calcium is on the lower side, 3.2. Phosphorus is also on the lower side, 2.2. Someone did a PTH level in this child and found to have a low PTH level and diagnosed this case as a case of hypoparathyroidism. Dr. Arpita ma'am, do you agree with this diagnosis?
Okay, so we have the phosphorus levels and the PTH levels. However, both of these do not corroborate, because in hypoparathyroidism we expect the phosphorus to be high. So I would like to know whether this PTH was properly collected or not, because as we know it is a thermolabile hormone. So the thing must have been that it would not have been collected or transported properly in eyes.
So ma'am has rightly said that PTH is a hormone that is a phosphaturic hormone. That means it increases the phosphorus excretion from the urine. So if there is PTH deficiency, the phosphorus should not be on the lower side. It should be on the higher side. So based on this calcium phosphorus level, we can say there is no chance that this child is having a phosphorus deficiency. So the only possibility remains here that there is a assessment error in terms of the collection or the transport. As we all know, the PTH is a thermolabile hormone and we should collect it properly. We should transport it using a ice. Probably this PTH was not collected properly, leading to a false low level of PTH in this setting. So moving on to the next case, case number 5, a 1-week-old boy presented with seizure and ionic calcium was on the lower side. His phosphorus was high, 9.1, and creatinine was 0.3. So Dhani ma'am, I would like to know your approach on this case.
So again, neonate presenting with hypocalcemia, hypophosphatemia points towards the possibility of a parathyroid hormone deficiency. But again, this could be a transient or a permanent form. One needs to look at maternal hypercalcemia, which can point towards a transient form. Other possibilities that of Digeot syndrome, so look for the clinical manifestation, low set ears, long face, cleft palate, heart defects, look for thymic shadow. So all these things can give you a clue to the diagnosis and will guide how long the child will need treatment or management.
Yes, ma'am. So the next best investigation was the PTH level, which came to low in this child, and the child was diagnosed as a case of Digeot syndrome with a cardiac defect. So we all have to remember this Digeot syndrome as CAS22, cardiac defect, abnormal facies, thymic abnormalities, lip cleft palate, hypocalcemia due to the microdeletion in the chromosome 22. And always remember the high phosphorus level, which indicates there is a chance of PTH deficiency in this scenario. Moving on to the next case, a 10-year-old boy presented with seizure with low ionic calcium level and MRI picture showing this. Dr. Nitin sir, I would like to give some more to this patient that has been found, as you can see in these pictures.
So these are the first eye sign is showing cataract. Second is we are seeing the fourth metacarpal is short fourth metacarpal, and subcutaneous nodules are there. So these are pointing towards the specific diagnosis, pseudo-hypoparathyroidism, in which parathyroid hormone level is very high, but it is not acting. So picture will be like hypoparathyroidism like picture. Calcium level will be low and phosphate level will be high.
So the next investigation you would ask for is the phosphorus level.
Okay.
This is high for this child. Creatinine was normal.
Creatinine should be normal. Okay.
And PTH was high. So as Sir has rightly said, that in cases of high PTH and high phosphate level, initially we have to do for the creatinine level. We have to see whether there is CKD present or not. If it is not present, there are two only possibilities present. Whether it is hypoparathyroidism versus PHP. So in a setting of high phosphorus and high PTH level, and these pointers, that is the AHO phenotype that is present in cases of hypoparathyroidism, the stocky build, round faces, obesities, brachymetacarpia, one should remember about the possibility of hypoparathyroidism, pseudo-hypoparathyroidism in that scenario. So now I would like to request Arpita ma'am to move further from here.
So moving further, we've discussed hypocalcemia. Another frequent problems we encounter in our OPD is bony deformities or rickets. Okay. So what exactly is rickets? We all know that it is the defective mineralization of the growing bone. Once the normal bone growth has been achieved, what we encounter is osteomalacia in the older age group adults. So before making a diagnosis based on the bony deformities like some chest deformities, widening of the wrist or double malleoli, we should always confirm it radiologically, because there are so many other mimickers of rickets. To distinguish between the mimickers and the rickets, we have to make the diagnosis based on the radiological appearance of the rickets. So this is a classical X-ray of the rickets showing the widening of the growth plate due to the defective calcification. There is cupping and fraying due to the metaphyseal irregularity, and splaying, which is the bending of the soft bones. In long-standing cases, we may also see bone resorption due to secondary hyperparathyroidism. Chances are that we may encounter fractures even, because we have seen cases of normal nutritional rickets having fractures and loser zones. However, in Western world it is not very common because they timely detect it. But we should keep our mind and brain open and look for the cause of rickets. Recently in the 2021, the guidelines by the IAP regarding the vitamin D deficiency and rickets have been revised. So in less than 1 year of age, daily dose of 2000 IU per day along with calcium is what is recommended. When there is a compliance issue, we can resort to alternative intermittent regime. However, it is not recommended below 6 months. There is no role of intermittent therapy below 6 months of age. Between 6 to 12 months, we can give equivalent of 2000 IU per day, maybe in a monthly or a weekly basis, which comes out to be 14,000 IU weekly or 60,000 IU monthly for a total duration of 12 weeks. In older children, more than 1 year, the dose of vitamin D is 3000 IU per day. Alternative intermittent dose is about 60,000 IU fortnightly, that is every 2 weeks for a total duration of 5 doses. So along with vitamin D supplementation, what we have to ensure is the daily calcium intake of about 50 to 75 milligram per kg per day. Otherwise, there will be hungry bone disease, and calcium supplementation is very important here before labeling the child as refractory rickets. So both calcium and vitamin D supplementation is important while we are treating rickets. Now the parenteral IM or STOS therapy is no longer recommended. Only place where we resort to parenteral therapy are the cases of malabsorption such as celiac disease. An optimum duration of therapy is 12 weeks or 3 months. Response to therapy is mainly seen by a decrease in the calcium levels initially. However, we need not monitor the calcium levels. We may just do the X-ray at the completion of therapy to look at the line of healing, which remains the gold standard. ALP, which was already increased in case of rickets, will further increase, and it should not tell us that the child is not improving. In fact, it is known to be increased while on treatment further because of the increase in the bone turnover. Bone pain will also increase while on treatment. So what is required is the assurance by the treating physicians to the parents of the child that these things are a normal response to the therapy and the therapy is working. When we do not encounter the line of healing at the completion of therapy, or predominantly the rickets is involving the metaphyseal plate, and there is a lack of response on the X-ray after adequate course of vitamin D and calcium, we should be thinking on the terms of refractory rickets. However, here also caution should be exercised before labeling the child as refractory rickets. Upfront, during the initial presentation also we can think about refractory rickets when there are certain signs or symptoms in the child in the form of polyuria, which may be a clue towards your RTAs, seizures due to the calciopenic rickets majorly, fractures due to VDDR or other problems, and growth failure or anemia pointing towards celiac or RTAs. So upfront we can label the child as refractory rickets if any of these symptoms and signs are present. False diagnosis, as I have already discussed, may be in cases of skeletal dysplasia, which is a closed DD of the rickets, which may have the X-ray findings also mimicking rickets. Whenever there is improper dose of vitamin D and calcium, rest, high LP and bone pain is bound to increase on treatment. So rickets is majorly classified as deficiency rickets due to calcium and vitamin D deficiency. We have to give vitamin D and calcium and look for the therapeutic response. When we have ensured proper treatment, we can label the child as refractory rickets, and refractory rickets further is classified into the calciopenic rickets, majorly due to the VDDR1 and VDDR2, vitamin D dependent rickets 1 and 2, renal failure and malabsorption. Because there is calciopenia, it will be early onset because of hypocalcemia. So the child may have symptoms of hypocalcemia in the form of seizures, and there will be high PTH expected due to the low calcium levels. The other cause of refractory rickets is due to the acidosis, maybe proximal RTA or distal RTA. Both of them will be having hypokalemia with acidosis. However, proximal RTA will present early due to hypokalemia, and distal RTA is known to be presenting late with severe fractures and severe features. So that's the difference, and both will have failure to thrive and polyuria, and distal RTAs may have nephrocalcinosis if there is USG-KUB done, and hearing defects are also known to be associated with RTAs. So acid status in case of refractory rickets is very, very important before diagnosing. However, caution should be exercised here also. We have to assess the child in total. We cannot just do a ABG and seeing the acidosis label the child as RTA, because we have seen children of CKD wrongly diagnosed as RTAs on soda bicarb therapy crashing in our ICU. So CKD is a thing which we have to rule out in such patients. The other variety of refractory rickets is hypophosphatemic rickets. Fanconi's anemia, which is due to the proximal RTA effect. It may be due to other diseases like cystinosis Wilson's disease, and due to the malabsorption. Hypophosphatemic rickets have a late presentation, and predominantly lower limb involvement is seen. Because there is no hypocalcemia, that's why they present late with majorly lower limb involvement. And there will be normal calcium and PTH levels. So we have to ask ourselves at each step, so whether there is rickets or not, or is it a ricket mimical like skeletal dysplasia, hyperparathyroidism and so on, and whether it is refractory or not, whether we have done proper treatment of the patient with proper dose of vitamin D and calcium, and depending on the cause, further management is then done. Investigations as in hypocalcemia, the first investigation and the most important investigation here again is phosphorus levels. So if it is high, there can be only 2 DDs, that is renal failure or pseudo-hypoparathyroidism. Urinary calcium is also an important workup in this refractory rickets, because we want to rule out the distal RTA which is high. The urinary calcium can be assessed in the 24-hour urinary calcium assessment, which can be cumbersome in children. So we may rely on spot urine calcium and creatinine ratio. If it is more than 0.25 milligram per milligram, it is diagnostic of hypercalciuria. The next investigation, if everything is normal, we should be doing PTH. If it is normal, it is hypophosphatemic rickets. ALP is higher in all the cases of So ALP is bound to be higher in all the cases of rickets except for RTAs and CKD. And it is low in condition where there is no ALP production in the hypophosphatasia. Acidosis is seen in RTAs and CKD. So before going on to the rickets classification, I would like to run through this algorithm. First, we have to ensure that we have treated the child with adequate doses of calcium and vitamin D for 12 weeks. And then if it is refractory, only then we need to do. Otherwise, a simple calcium phosphorus ALP as well as an X-ray confirmation of rickets is all what is needed in nutrition. So once we have done and ensured that phosphorus needs to be evaluated, if it is low, we then we should be thinking on the lines of RTA, and based on urinary pH levels, if it is higher, then distal RTA, if it is below 5, it is proximal RTA. If the blood gas is normal, we should be looking at the calcium and the PTH levels. If it is normal, it is hypophosphatemic rickets. If there is low calcium with high PTH, we should resort to calcitriol. So only in selected cases calcitriol is actually needed. because it is not under the control of PTH. So calcitriol will further establish the diagnosis of VDDR1 if it is low, and VDDR2 when there is high calcitriol. If the phosphorus is high, we have to rule out CKD, where the creatinine will be high, and if the creatinine is normal, we are having the diagnosis of pseudohypoparathyroidism. Now I would like to call upon Alapin for the So if we are sure of the dosage and duration, only one course is what is needed. But if we are not sure, we can at least repeat one course and then we may see the X-ray. If it is not improving, then we may evaluate for refractory rickets.
Yeah. I think that's a very, very important point. So the main problem in somebody who has come to us with hypocalcemia and not rickets means that the duration probably was not that long enough. And the second thing is that in these cases what we do is that we give them a course of calcitriol to bring their levels up, and then they do not need this high level. This is for somebody who has established rickets. Now frankly at this age not too many will come to us with rickets. So this 2000 dose is definitely much higher than what we should be giving for a longer duration. I would usually be using somewhere around 1000 to 1500 maximum. But the key message there would be that in the initial phase calcitriol is very, very helpful because to build up the dose. Yes.
Okay, so then now we feel that let's do vitamin D, especially for babies who are premature or babies who are SGA. And we find dismal levels of vitamin D, something like 5, 3. So then the guidelines say they are for rickets as well as for vitamin D deficiency. So thinking of vitamin D deficiency, we started giving this 2000 units of vitamin D to these babies. Initially blindly for 12 weeks, but then because it's very vitamin kid-rich drops, 2.5 ml per day. You feel scared कि क्या कर रही हूँ मैं. So then when we did the vitamin D levels, we found that the levels were 80, 100 often in between. So क्या करें?
I think that's a very, very important point. Generally, we were not going that high level in terms of the initial replacement. We were saying, okay, 400 may be required, and then you go up to 800 or 1000 in terms of therapeutic range in the 1 year. But this guideline is going a bit higher. So generally, I am not going towards those levels because that definitely will have a tendency of hypercalcemia. And the evidence, actually there is not too much evidence in terms of these guidelines which have come up. They come up mainly from the international guidelines and they have been brought in. We should actually have a randomized trial to really look into what really is the optimum one. Dr. Ayesha was part of the committee, so I'll maybe ask her opinion. You were part of the guidelines committee.
For neonates especially, there are not many evidence. Maybe we have better evidence. So 2000 because and you have to keep monitoring. Okay, so yeah, no, monitoring is a part of that guideline. You have to keep monitoring those children for features of hypercalcemia, definitely. So because for infant, what we found out, there was not much evidence available. Beyond that, we have a lot of studies, and those are also not many RCTs in infancy per se, and especially for newborns. So we stuck to the evidence that we have from Western population, and we are continuing with that. So vitamin D levels. Okay. So I would say still 2000 if it's quite low. It's quite low, na? 5. No, for even asymptomatic.
Yeah. So I think the problem basically here, Dr. Nishant and Dr. Aisha, is that there is not much evidence. So the guidelines is mainly extrapolating from the external sources and basing that the therapeutic window of vitamin D is very large. So they say 400 is okay. So US guidelines were saying you can go up to higher doses, and that's how it come out. In my personal experience, and as you were suggesting, we are a bit cautious. We probably will not go above 1000. But I think another very important message that initially, unless you give them calcitriol, they will have hypocalcemia for a long time. I think that. So these are different ball game altogether.
In that case, there was no, in 400 was the optimal dose for Indian scenario. Yeah. For, as a supplementation for newborn baby. So in some group, mother was supplemented, but you all know the breastfeeding is never, breast milk is hardly 40 units average per liter, that is. So in that case, there was PTL level little high, and direct supplementation 400 was, and we also followed it till 1 year. So that was an RCT published in Peadiatric, European Journal. So, and otherwise, there is a concern whenever you use even 800 or 1000 units. So ideally, you should monitor whether it's a PTH and hypoglycemia. Canadian recommendation, they are 800 IU. Canadian 800, and there are varied recommendations. So Canadian is something who, because of sunshine, is low. So we also standardize sunshine, how much with picture and all.
I think that's one of the issues which maybe there is, that they are not differentiating symptomatic versus asymptomatic. That will be an important point to look at. Hypocalcemic seizures, ma'am. So infants typically. So I would say in neonates, probably we may not be monitoring regularly vitamin D in clinical practice. Giving them maintenance dose is what we do usually, unless they have hypocalcemia. And when they say rickets, it's very, very unusual. Very early rickets will not happen. So in that case, the 2000 unit is, I would say, supraphysiological, but I think there is a scope for continuation.
So I'll start with the cases. This is a case number 7, 3-year-old boy presented with features of rickets, given vitamin D 60,000 unit for 3 doses. Now the patient presented to us with bone pain and a high alkaline phosphatase level, and calcium is 9.4. And he was diagnosed as a case of refractory rickets. His parents were anxious and they wants to know whether this child is deteriorating or what is the case, ma'am.
So as already mentioned, that we have to ensure that there is adequate supplementation and dose of vitamin D and calcium before labeling the child as refractory rickets. So here only 3 doses were only given, and as in the X-ray also there is a normal line of healing which I can see. So this is the case of wrongly labeled refractory rickets, and we should counsel the parents, and whatever is their concern that the bony deformity is there, that will not go altogether, the symptoms will not progress further. So maybe an orthopedic reference may be done in the same child.
So as ma'am has already said that the high ALP level and bone pain are the responses to the vitamin D. So there should not be any further workup in regards to that, and line of healing is the best marker for healing of the rickets. Now moving on to the next case, a 4-year-old girl presented with rickets, given calcium syrup of 5 ml BD and showing no improvement after 30 days of treatment. There was no line of healing also present in the X-ray, and also again diagnosed as a case of refractory ricket. Dr. Dhani ma'am, I would like to know whether this diagnosis is right or wrong.
So again, when you have a child with rickets, you give them vitamin D and calcium before labeling them as refractory. So again, as per the IAP guidelines, you give them 2000 units daily for 12 weeks, or you may give in older children 60,000 bi-weekly. And after giving vitamin D, you decide whether or not they are refractory.
So adequate dosing, the most important thing for adequate time, as well as there is no role of the parenteral vitamin D as had already been discussed, which is only used in cases of malabsorption like celiac disease. Moving on to the next case, a 5-year-old girl presented with rickets with features of polyuria. He has a significant growth failure in terms of height 88 centimeter and weight of 10 kg. Now, ABG was done showing a pH of 7.1 acidosis and labeled as distal RTA. Dr. Nitin sir, I would like to know your approach to this case.
So according to algorithm, we should first do phosphorus, and if phosphorus is high, then we should do creatinine.
Yes.
And if creatinine is high, then it will be CKD, and if creatinine is normal, then we should think of pseudo hypoparathyroidism. So our algorithm was not followed,
Yes.
and directly we have done ABG. So
Yes.
phosphorus is high as in this case, and creatinine is also high for this baby. So this is a case of CKD, not the acidosis.
Yes. So we should always rule out rickets as well in the hypocalcemia and also rickets. The CKD we should also be ruled out before diagnosing any other diagnosis. So now the next case, a 12-year-old girl presented with multiple fractures. He had other symptoms like failure to thrive, polyuria and myopathy. So Arpita ma'am, I would like to know your plan of management in this case.
Okay, so this 12-year-old girl has other problems in addition to rickets. She has late presentation with fractures, most probably.
Yes, as ma'am has correctly said, that in cases of acidosis with rickets, there are two possible diagnoses. One is CKD, another is RTA. Both could be differentiated by using the phosphate level. The phosphate level is usually high in cases of CKD, and it should be in the lower range in cases of RTA. Also, the next case, a 14-year-old boy presented with refractory rickets, and the picture of the child as well as his bone X-ray. Pradhani ma'am, your opinion regarding this?
So what we can see in this, in these two images is a boy with genu-varum deformity, and if you look at the hand, there is no cupping frames playing in the X-ray wrist. So this tells you that there is predominant lower limb involvement, male gender. Think of hypophosphatemic rickets in this setting, and again doing the phosphorus levels will
yes, the phosphorus level is 1.8 with a base excess of -4.
So no acidosis again.
And the calcium and PTH level was done, it's showing in the normal range.
So again this points to hypophosphatemic rickets here.
So as ma'am has said, the hypophosphatemic rickets are usually the late onset ricket, are less severe than calciopenic. So usually predominantly involves the lower limb, and there is usually a normal calcium and PTH level in that scenario. So I think
इलेक्ट्रोलाइट DSC डॉक्टर युतिका के टाइम में कर सकते हैं.
Now the mementos to the speaker, Dr. Arpita ma'am. Chairpersons, Professor Mala ma'am. Professor Chandrakanta ma'am. Dr. Pragati ma'am. Panelist, Dr. Nitin sir. Dr. Dhwani ma'am. Now let's begin with the third module, that is on electrolytes. I would like to invite Dr. Anurag sir, and for the chairpersons I would like to invite Dr. Sanjeev Kumar Verma sir and Dr. Sharat Kumar sir.
So Sanjeev sir is additional professor in Department of Pediatrics, KGMU, and is looking after pediatric gastro unit. And Dr. Sharat Kumar Singh is the head, Prasad Institute of Medical Sciences, Department of Pediatrics. And we all know Anurag sir, and he needs no introduction. He'll be the speaker for the electrolyte session. I would also request the panelist, Dr. Vishal Punya sir. He's additional professor in the Department of Pediatrics and looking after pediatric nephrology here. Dr. Nishant Verma sir, additional professor, Department of Pediatrics, in charge pediatric oncology, and Dr. Dhwani.
Discharge ovulation. Okay, so by the time, oh, mic. So by the time the technical glitch is taken care of, I'll touch base basically about electrolyte disorders, and we know that there are two major electrolytes which will focus on the sodium and potassium. And generally the body goes in a manner that if your sodium is high, your potassium goes down, and if your sodium is low, potassium should be high. So generally there is a reciprocal association of that. The sodium levels in the body are largely determined by the amount of water and not by the amount of sodium. So if you talk about hyponatremia, it is usually because of too much free water like SiADH, and if you talk about hypernatremia, it is because of too little free water like typically diabetes insipidus. So free water is more important as compared to the sodium. Now sodium regulation, as I said, free water becomes important, and free water is regulated largely via the posterior pituitary using the antidiuretic hormone. So whenever our osmolality goes up, your sodium level goes above 144 to 145, the process of AVP secretion triggers. The posterior pituitary will start AVP secretion, it is going to concentrate the urine, retain the water, and your sodium will become normal. Vasopressin is also involved in other blood pressure regulation, but its primary role is in terms of osmotic regulation. In volume depletion, now if I talk about sodium, I said water is more important. When you talk about volume, what is more important is sodium rather than water. It's an interesting, I would say, corollary in that perspective. So when you have a volume problem, the body will like to build up the sodium level. And this is basically done using the renin, angiotensin, aldosterone system. So as soon as your volume becomes less, the juxtaglomerular apparatus gets less blood, it produces renin, from there you have got angiotensin which produces aldosterone, and the whole process goes in. Now the RAS pathway will in a way increase sodium absorption, but when you are increasing sodium absorption, you have to exchange this sodium with some positive ion. The most common one is potassium. The other ones which can also be there could be calcium, could also be proton. So whenever you are retaining sodium, you will clearly have a scenario in which you will have, in a way, losing potassium causing hypokalemia, losing proton causing alkalosis. So a normal response to RAS excess is hypokalemia and alkalosis. So high sodium, low potassium, that is the classical scenario. Now if you have a RAS defect like renin deficiency, aldosterone deficiency, aldosterone resistance, pseudohypoaldosteronism, you will have hyponatremia and you will have hyperkalemia. Along with that, you will have metabolic acidosis, which will be hypochloremic in that perspective. But if you have too much of aldosterone excess, your sodium will go up. Immediately body doesn't want your sodium to go up, so it will produce another substance from the heart, which is the atrial natriuretic peptide, which will really push off your sodium, and there will be no edema and there will be no excess in terms of the sodium level. So long standing hyperaldosteronism presents to you with hypokalemic alkalosis and not predominantly with hypernatremia or edema. That becomes important from that regards. Now when you talk about potassium, potassium is largely an intracellular ion. So the hypokalemia or hyperkalemia is usually because of redistribution of this potassium between the cells as well as the external environment. So clearly in that scenario, if you have insulin deficiency, if you have metabolic acidosis, the potassium will go out of the cells. When you treat it, you have hypokalemia which is going to develop on that in regards. When you have hypokalemia, the body would want to preserve potassium. So potassium will not be lost in the kidneys. So when you are not losing potassium, you have to basically lose some other positive ion, and that other positive ion is proton. So whenever you have hypokalemia, you would lose proton outside, therefore you will have hypokalemia with alkalosis. So everybody who comes to you with hypokalemia should have alkalosis. If there is hypokalemic acidosis, the causes are very, very limited. It is renal tubular acidosis. You are losing both bicarbonate as well as potassium from the gut or from the kidneys, or diuretic would be the diuretic of the acetazolamide type of diuretic will be the other scenario which can cause that. Now third thing to remember is that if you have too much potassium, then you will want the potassium to go out. Now this potassium is not going out, so you will be competing with proton. So proton will be retained. So anybody who has hyperkalemia will have acidosis. So this basically is a typical scenario in which you have hyperkalemia with acidosis, which is type 4 RTA. So I think this is the main scenario to think of. So is it getting charged?
किस आईडी पे करना है? फरहान किस आईडी पे? हाँ, ईमेल आईडी बोलिए। पेन ड्राइव सर
इसमें पेन ड्राइव नहीं लगेगा, वो दे दीजिए आपका अडेप्टर।
पेन ड्राइव, हाँ पेन ड्राइव।
नहीं अब तो चलने लगा ना, हाँ यहाँ से कर दीजिए, यहाँ से कर दीजिए, इजीएस्ट रहेगा।
ले लेते इसमें, अगर बीच में बंद होगा।
नहीं अब बंद नहीं होगा ये।
फिर हम यहीं से कर दिए।
अच्छा बट ये चार्जर यहाँ लगाना पड़ेगा।
defects of micropenis can help us guide the diagnosis. Okay,
In
so
this case, the sugar was on the lower side, ma'am.
ketotic
and-
hypoglycemia.
Yes, ma'am. Ketones
So
were
again-
positive. And this is the clinical picture of the patient, ma'am.
So again, this
what do you think,
points
ma'am?
towards MPHT. One needs to look for FT4 and cortisol levels and replenish, give hydrocortisone replacement therapy in this child.
The cortisol was low and the growth hormone was also low for the level of hypoglycemia. So it was a case of hypopituitarism.
Supplementing cortisol here will itself correct sodium levels, and no additional therapy or 3% saline needs to be given here.
Thank you, ma'am. So the key message here is that cortisol level and free T4 level should always be done in case of euvolemic hyponatremia, and cortisol level below 550 is low in this case. 14 years old boy presented with drowsiness, sodium was 116, he was euvolemic, urinary sodium was 110, 100, osmolality, urine osmolality was 300, and he was labeled as SIDH and was started on fluid restriction. So Dr. Nishant. What will be the ideal approach?
So in this child, again, going by the algorithm, so although SIADH is a common cause of euvolemic hyponatremia, but before labeling any child as SIADH, we need to confirm that by first ruling out hypothyroidism and hypocortisolism, so which needs to be tested first. So in this child, the thyroid levels were low, and even the cortisol was low for his level. It should be, normally it's more than 550, so both are low. So again, it's not SIADH, it is actually multiple pituitary hormone deficiency, and the child needs to be treated for that rather than fluid restriction.
Thank you very much, sir. The key message again here is that SIDH is a diagnosis of exclusion. We should always do cortisol and free T4 before labeling the patient as SIDH. 3-week-old child, there was failure to thrive, sodium was low, 110. Birth weight was 2.5 kg, and presently the baby is 2.6 kgs. Dehydrated, the hematocrit was high, urine sodium was 100, and the potassium was 8.4. So Dr. Vishal, sir?
So as we can see, this child has hyponatremia and dehydration. So we have to go to the limb of the algorithm where there is volumic hyponatremia. And this child also has a high potassium levels. So because the potassium hypovolemic, and we look at the urine sodium, which is high, and potassium levels are high, so we reach up to the RAS abnormalities, RAS defect, or the aldosteronism defects.
This patient also had, sir, a typical genitalia.
Yes, so we can see in the picture that this child has ambiguous genitalia, and according to that, we can think of the congenital adrenal hyperplasia. So 17 hydroxyprogesterone levels were done, which were found to be high, and so this child is suffering from 21 hydroxylase deficiency.
Thank you, sir. So hyponatremia and hyperkalemia is RAS defect, and if there is atypical genitalia, we should always suspect CH. 6 months old girl was labeled as cystic fibrosis, and she had recurrent chest infections. There was failure to thrive. Sweat chloride was 120. There was no steatorrhea. Sodium was low, and the potassium was 6.8. So, Dr. Dhani, ma'am, what will be the approach, ma'am?
So here what we can see is hyponatremia with hyperkalemia. Children with cystic fibrosis have hyponatremia as well as hypokalemia, not hyper. So very close differential clinically is pseudo-hypoaldosteronism here. So again, when you have hyponatremia, you look at the volume status. In a dehydrated child, you look at the urine sodium. Urine sodium here was high, points towards a renin-angiotensin pathway defect, and we need to look at the aldosterone levels here.
In this case, both were high, ma'am. Renin and the aldosterone levels are high.
Both were high. So yes, this points towards a resistant state, aldosterone resistance. So
Thank you very much, ma'am. So again, salt wasting with recurrent chest infection is a case of pseudo-hypoaldosteronism, and it's a close DD for cystic fibrosis. In this case, there will be high renin and there will be high aldosterone levels. 1 month old boy, reduced feeding, Birth weight was 3.1 kg and presently is 3.2 kg. Sodium 124, potassium was 6.8. 17 OHP and cortisol level were within normal limits. PRA was 12 and aldosterone were 200. So Dr. Nishant sir, how will you move ahead with this case, sir?
Yes, so again going by the algorithm, it looks like similar to the previous case, but before labeling a child as aldosterone deficiency or aldosterone resistance, we need to rule out certain common causes. So we know that even during UTI and in obstructive uropathies, there can be transient aldosterone resistance, which would mimic a clinical picture similar to aldosterone deficiency. So in this child, doing a urine routine microscopy showed that there were more than 100 WBCs, which means this child is having UTI. And some ultrasound was also showing obstruction, and both these things can cause transient hypoaldosteronism-like picture. So this child most likely has this and needs to be managed for that.
Thank you, sir. So this patient had transient pseudo-hypoaldosteronism. And in that case, we should treat the patient, and that will lead to the improvement of the status.
So hyponatremia is much more common, and I would say the most common causes of hyponatremia as discussed would be CH in the newborn period, SIADH in the older child. Hypernatremia is less common, but two causes you should always consider. One is what is known as breast milk related hypernatremia, typically happening in early onset primigravida children, typically presenting at 2 to 3 weeks of age with very, very high level of sodium. And second, chronic will be diabetes insipidus. These are the two ones which are common. So hypernatremia, as I said, usually is because of reduced free water. If you have reduced intake like neonates, or in those scenarios adipsia where somebody is not taking water, you may have a problem. But most commonly this is because of increased loss of free water. Increased loss of free water can be extrarenal like diarrhea or sweating, in which your urinary sodium will be low, or it could be, if you talk about long standing, it will be things like diabetes insipidus, where you will have osmotic diuresis in that regards. Sodium load is a rare cause of hypernatremia, because if you have too much sodium, ANP comes into the picture and that will going to drive it off. But it may happen rarely with ORS. If your ORS is not properly formulated, it is too concentrated, you may have hypernatremia which will happen. Typically here your urinary sodium will be high and the child will have fluid overload. So the approach for hypernatremia is, first of all, rule out a salt load, rule out diabetes because you may have osmotic diuresis. Then you look at urinary osmolality. Anybody who has concentrated blood should have concentrated urine. High serum sodium, high urinary sodium. But if you have dilute urine, that is diabetes insipidus. End of the story. If your sodium is above 146, your urinary osmolality is less than 600, this is DI, you do not need to do anything. Doing a water deprivation test will be lethal because he is already dehydrated and he will die if you do a water deprivation test. In that case, look at AVP response. If body is responding to AVP, this is central. If the body is not, this is nephrogenic DI. On the other hand, if you have high urinary osmolality and high urinary sodium, this is sodium load. Otherwise, this could be a extrarenal loss or osmotic diuresis. So we can start off with the cases.
So the next case is, this is 3 months old girl. She had altered sensorium and sodium was 170, potassium was 4.2, urine osmolality was low, it was 110. She was advised water deprivation test, and sir, what do you think about this, sir, in this scenario? Dr. Vishal?
So actually, as already pointed out by Anurag sir, this child has hypernatremia with a low urine osmolality. So already serum osmolality is high, child must be dehydrated. So we should not do water deprivation in this child because already there is hypernatremia. So if we look at the algorithm, this is most likely diabetes insipidus. We don't need to advise a water deprivation test in this child. We should look at the AVP response.
Sir, AVP response was present.
So if the AVP response is present, this is a case of central DI. So that is the way to diagnose.
Thank you very much, sir. So the key message, in case of hypernatremia, there is no need of water deprivation test. 14 days old girl, she had failure to thrive, birth weight is 2.6 kg, and now presently she is 2.3 kg. She was exclusively breastfed, mother being primary, the sodium was 182, urine osmolality was 1000. Dr. Dhoni ma'am, what will be the approach in this case?
So as sir pointed out, in the neonatal period, if you have hypernatremia, you think of two important causes, either DI or breastfeeding, inadequate breastfeeding. High urinary osmolality suggests that there was free water deficit, and this points towards a breastfeeding deficiency, like inadequate feeding that has led to this increased sodium concentration.
Urine sodium was also very high. So it was a case of increased sodium load, which was related to the breast milk related cause. So the key message, high serum and high urine sodium is due to increased sodium load, and in case of primary mother, it may lead to breast milk related hypernatremia. 13 years old boy presented with encephalitis. He was on a ventilator. There was a polyuria with 10 ml per kg per hour of urine. Sodium was very high, 180. The urine osmolality was 120. Post-AVP response was positive. And Dr. Nishan sir?
So again, the clinical picture, hypernatremia with low osmolality of the urine suggests that this child has DI. And looking at the clinical scenario, a child who is having encephalitis, it looks like brain death related DI. So this child most likely has brain death related DI. There are two approaches to management. Either you just give fluid, as much the child is losing, you continue giving fluid, or you can even try vasopressin, but ultimately because this child has brain death, it is the other things which come into picture more important than DI in this child.
Thank you, sir. So the key message, in a critically ill child with sudden onset of polyuria, we should always suspect brain death related DI, and the treatment will remain fluid replacement along with AVP.
So just a few words before we wind up to hypokalemia. Whenever you have chronic hyponatremia or chronic hypernatremia, be cautious in terms of correction. Often we get children whose sodiums are 115, 120, and people want to say, okay, let's give us 3% saline, or if somebody has hypernatremia, give a lot of free water. No, if you have chronic hypo or hypernatremia, the brain has adapted. So in that scenario, you should not make a change above 6 millimoles per liter in a 424 hours. This is important. The only indication of 3% saline is somebody who has symptomatic hyponatremia in the form of seizures or features of raised ICT, and again hypernatremia, be cautious. So that is an important thing to remember. Now hypokalemia, as I discussed, most commonly may happen because of shift of potassium to the cell. So if somebody is giving insulin beta agonist, or it could be a loss of potassium in the extrarenal because of diarrhea. Here your urinary potassium will be on the lower side, or because of a urinary loss of potassium. Urinary loss of potassium, of course, will have a RAS dependent pathway where you will have hypertension, and this will be Liddle's or AME like scenarios, or you will have a scenario in which you have RAS independent like tubulopathy, in which you will have alkalosis, and RTA you will have acidosis. So three things what I am trying to say out here is that when you have hypokalemia, look at urinary potassium, look at blood pressure, that becomes important, and blood gas. These things will give you a clue. So normally if your urinary potassium is low, it is somewhere else you are losing potassium. If it is high, it is coming from the kidneys. Then your blood pressure is high, this means your aldosterone is working more. So this will be the scenario like hyperaldosteronism, Liddle syndrome, or you may have 11 beta hydroxydehydrogenase deficiency 2. These are rarer ones. I am not going to go too much into that perspective. But if there is acidosis, then you have only two differentials, renal tubular acidosis, or you have a gastrointestinal loss in that perspective. So if you talk about hypokalemia, I would say the most important thing is pH. That will give you a cause. If acidosis, RTA versus diarrhea, alkalosis could be RAS excess or tubulopathy from that perspective. Now approach, as I again said, look at blood gas. Metabolic acidosis, your role is to distinguish predominantly with regards to whether this is a case of RTA or a GI loss. Look at urinary anion gap. If urinary anion gap is positive, it means that the ammonium production is defective, and this is RTA. If urinary anion gap is negative, that means ammonium production is preserved. This is the GI loss. So I think that arm is very simple. If you have alkalosis, look at blood pressure. If there is hypertension, then your differentials start in a different way. Look at aldosterone. If aldosterone is high, that is a RAS problem. If aldosterone is low, then you go for CAH variants, you go for Liddle and other scenarios in that regards. If your blood pressure is normal, you are looking mainly at hypomagnesemia, you are looking at Bartter syndrome or Gitelman syndrome. So in that scenario, you look at urinary calcium to classify. So I think simple approach, look at common causes like diuretics, malnutrition and GI loss first, then you look at acidosis, alkalosis and then classify from that perspective.
Two-month-old boy presented with hypokalemia, potassium 2.8, pH was 7.16, bicarbonate 14, anion gap of 12. So, Dr. Vishal sir, what do you think? How will you differentiate this case?
So this child has hypokalemia along with acidosis. So we have to differentiate between whether the potassium is being lost by the kidneys or in the diarrhea. So we will have to look at the urinary anion gap.
So in this case, sir, the urinary anion gap was...
urine, here we can see the urine anion gap is negative. Sir. That means there is a GI loss. So most likely diarrhea is the cause for this scenario, sir, not RTA.
Sir. Thank you, sir. RTA versus diarrhea, it will present with acidosis and low potassium. So urinary anion gap is the clue. If it is positive, it is RTA. If it is negative, it is diarrhea. 3-month-old girl, she presented with failure to thrive. Potassium was 2.2. Birth weight 2.8 kg. Presented now at 3 months with 3.5 kgs. She had alkalosis. Bicarbonates were 33. BP of 70/40, which was normal. So, Dr. Dhwani ma'am, what will be the approach?
So again, in the setting of hypokalemia and alkalosis, you look at the blood pressure. If your blood pressure is normal, like in this case, you will want to rule out tubulopathy like Bartter or Gitelman, or an external diuretic use if there is.
In this case, there was nephrocalcinosis.
So this points to hypercalciuria and Bartter syndrome, and it should be considered here.
Thank you, ma'am. So this was Bartter syndrome. So normal BP with alkalosis is usually Bartter syndrome, and hypercalciuria and nephrocalcinosis gives the clue. 8-year-old boy presented with early puberty, height was 134, pH 4, and there was metabolic alkalosis, bicarbonates 34, potassium 2.6, urine chloride were 100, BP 120/74. Sir, Dr. Nishant, sir.
So here again, early puberty, hypertension, alkalosis, going to the other limb where you can see that most likely it is something related to the RAS pathway. We need to check the aldosterone. If the aldosterone is high, then it's RAS related. It's low, then some kind of CAH. And again, cryptorchidism is pointing towards CAH here. So we need to check this 11 for 11-hydroxylase deficiency. So this child most likely has 11-hydroxylase deficiency.
Sir. Thank you, sir. So hypertension with alkalosis, we are dealing with CAH. And XXGSD, 11-hydroxylase defect is the very important cause.
So I think this you should consider as a primer for electrolyte disorders, because of course it's such a vast topic we can't cover in 45 minutes. There are many of these modules which are available separately. There is a PG lecture series which you can go and look at the YouTube, in which we have got full 1-hour session of hypokalemia, hyperkalemia, hyponatremia, hypernatremia, which covers everything. So that will be another way to go for. This is more to stimulate you from that perspective. Don't get scared by electrolytes. These are something which are very common and important, and you can easily identify that from that perspective. Before I hand over to the organizer, there is an announcement that we are going to have a quick quiz in the post-lunch session, which will be done via the Google form. So all of you, when you're going for lunch, in the stall there is a quiz QR code which you can scan, There are 15 questions, and we have got 2 categories for practitioners as well as postgraduates. 10 minutes you can fill them, and there are very attractive prizes which are also there, which we'll announce on that. So all of you please do participate in the quiz, and over to you.
Now let's present the memento to our speaker, Dr. Anurag sir. To the chairpersons, Dr. Sanjeev sir. And to Dr. Sharad sir. To the panelist, to Professor Nishant sir. To Vishal Punya sir. And a floral bouquet to Dhwani ma'am. With the first half of the course completed and the time now 2 o'clock, let's head down to the ground floor for the lunch. Please reconvene here in the next half an hour.
चार्ज हो रहा है ना मेरा? कितना चार्ज हुआ?
22% हो गया, चार्जिंग हो जाएगी।
Good afternoon, everyone. Continuing with our next session on growth, please join me in welcoming our next speaker, again, Dr. Anurag Vajpayee, sir. The chairperson for the session are Dr. Nirmala ma'am, President, Lucknow Academy of Pediatrics, Dr. Ekant, sir, Joint Secretary, Lucknow Academy of Pediatrics, Professor and Head, HIM Sitapur. And the panelists for this sessions are Dr. Nitin, Dr. Utkarsh, and Dr. Arpita ma'am. Kindly take the seats. Yes, sir.
So before we start the session, after the growth session, we will have this quiz, which will be a very short quiz, Google form based quiz. So all of you would need to scan the QR code in your phones and you can answer that. There will be 15 questions in a 10-minute period. So this will be opened after this growth module is there, because some of the growth questions will also may be there. So it will be easier to answer on that. There are some very good interactive prizes as well. So we have got two categories for PG and trainees. For PGs, we have got the postgraduate course, which is basically a 3-year course covering around 40 modules in pediatric endocrinology. And then adolescent endocrinology and neonatal endocrinology, again extensive courses. So this we'll be doing at the end of this module. So growth, I think, is central to the overall aspects of pediatrics. And the most important thing which differentiates a child from the adult is growth. So we are trying to focus on growth and obesity. So we have a 12-year-old child who comes to us with complaints of short stature. The questions which are basically there is, what is the cause of this growth failure? Dr. Arpita, this seems to be stuck. So the main question is it physiological or pathological? Most cases that come to us with growth failure have a cause which is basically a physiological cause, but there is a substantial proportion off करना पड़ेगा. ये कुछ गर्म हो गया इधर से passport. Again, apologies for the delay. So we have got this child who is 12-year-old girl with short stature. The question is whether it is physiological or pathological. Now 80% of children who come to us with short stature and maybe 90% for a pediatrician do not have a pathological cause. But the problem is 10% may have a serious underlying disease which could be a craniopharyngioma, which could be a renal tubular acidosis or a celiac disease. So the task of physician treating with short stature is not to do unnecessary workup in those 80% while not missing those cases of pathological short stature. So when we talk about growth failure, we can classify growth failure into physiological or pathological. Physiological basically means constitutional delay of puberty and growth, and familial, which basically is being identified based upon two things. Is the child short for the family or not? This will give you the familial short stature. And is the child short for the bone age or not? So if you have a child who is short for the population but not short for the family, this is familial short stature. Not short for bone age, that is CDGP. So 80% of your work is done if you look at familial component and you look at the bone age. Now in the pathological causes, you have got primary versus secondary. Primary means intrinsic problems, which could be small for gestational age, this could be Turner syndrome, this could be some of those dysmorphic syndrome or skeletal dysplasia. Here if you look at the child, take a history, look at the facies, upper segment, lower segment, you will get the diagnosis. And finally we have secondary causes which include nutritional and endocrine causes. So mostly we reach up to the secondary cause. The question there is it nutritional or endocrine? And again, it's a very easy thing to look at the weight. The most important thing to look at in a short child is the weight, which will classify them. If you have a lean and short child, this is nutritional. If you have plump and short child, this is an endocrine cause. So we use a surrogate marker of BMI standard deviation score to identify that, which I'll talk later. Questions are, is it short stature? Is it physiological or pathological? Then if it is pathological, primary or secondary, and finally nutritional or endocrine. So first issue is, how do you define short stature? Now it is difficult because it is a statistical definition. You don't have anything like diabetes complications to say, okay, beyond 127 fasting I will have complications. So how do you go about that? So what we did was that we studied in a large population, and what we found that chance of pathology is very less if the height is below -2 standard deviation score. And if you go beyond less than -3, then in that scenario the pathology becomes too much. So what we are trying to say is that if you have a height standard deviation score more than -2 standard deviation score, don't worry, it's usually a physiological form. It's not even short stature. -2 to -3 you need to worry. This could be a pathological cause in 40 to 50% cases. But somebody who is below -3 standard deviation score, there is a very high likelihood of pathology. Now you may say it is 2 and 3 standard deviation score, how does it matter? It is actually like a Richter scale. It's not a linear scale, it is a very significant scale. So when I say -2 standard deviation score, the chance is 1 in 40 for a normal individual. But when I say -3 standard deviation score, this is 1 in 1000. So what it means that -3 standard deviation score is 25 times less likely compared to -2 in a population. So if you see somebody with -3, there is something to worry about. And we can go by percentiles also. So if your height is definitely below the chart, much below the child, this is definitely requiring evaluation. If the child is below the chart, then you can follow up for some time, and if the child is short and not growing, that also becomes a criteria. So what we say is that if the height is between 1st and 3rd centile, and the growth velocity is below 25th percentile, short and not growing, you need to worry. But what about this child who is just in the normal range? Mother is really worried. What we are seeing is that he is not growing at all. So this is another significant scenario, and I would be more worried here because this is an acquired cause of growth failure, and this could be something like hypothyroidism and a brain tumor. So very short, not growing, or not growing at all. These are the 3 causes you need to evaluate. Now why I am talking about SDS versus percentile? When you say less than 1st percentile, everybody is the same. But when you say -3 SDS, -4 SDS, -5 SDS, I know how severely that child is affected. Now you can easily get a standard deviation score from so many tools which are available, so it's not a problem. So you should go ahead with do the SDS scoring in that regards. Once you know that the child is short, the next question is it physiological or pathological? Now to answer that, you have to look at three things. One is the growth chart, second is the pubertal status, and third is the bone age. Before you write any investigation for a child with short stature, unless you have done these three things, you are not justified to write, and sir was just telling us that how growth chart is very, very important. So growth chart, puberty and bone age is extremely important. When you look at growth chart, you are looking at three things. Absolute status, how is the child compared to the population? So what you are looking at, either percentile or, as I said, better would be get that. Then you compare to the parents, and we all know that for that we take a mid-parental height, both average height at 6.5 to boys and -6.5 for girls. And then there is a range of approximately 1.5 standard deviation score from that point to get the figure. So basically you get the target height and target height SDS. Our application gives you corrected height standard deviation score, which is the best marker of what is the child's height compared to the actual height of the parent. So this will give you a true picture from that regards. If the child's corrected height SDS is more than -1.5, the child is either normal or familial short, it's a familial short stature. Third is nutritional effect, and as I said, you can look at height age and weight age, or you can look at BMI standard deviation score. In our data of around 900 children, what we found is that if your BMI standard deviation score is more than -1, this is indicative of an endocrine pattern, and less than -1 is indicative of a nutritional pattern. So either you use weightage or weightage, or you use this as a criteria. Having said that, there are two conditions which are exceptions to the rule. We have seen celiac disease in patients who have normal weight and even overweight. And we have seen hypothyroidism also happening the other way around. So TSH and TTG are routine evaluation for everybody, whether or not the BMI SDS is low or not in that perspective. Now pubertal progression is extremely important, and often we tend to miss on the Tanner staging. So if you want to do a quick Tanner staging, look at 2 points which are very, very relevant. Whether there is stage 2, which is the point from which the breast development starts. From here, the girl has approximately 2 years to grow, and 2 years to lead to menarche, 2 to 2.5 years, and from here the growth will be around 20 centimeters. Now the problem is, often because of obesity, patients are unnecessarily labeled as having thelarchy. So how do you identify true thelarchy? Is to approximate your thumb and finger, and if you really find a resistance, that is a breast tissue, and this is what is B2. So while the classic Tanner staging is an inspection phenomena, here what we are looking at is that palpation also becomes important in confusing scenarios. The second stage you should know is breast stage 4, where the secondary mound is formed. Because from here you have got around 10 centimeters to grow. Then menarche, the growth is 5 to 8 centimeters. How do you know menarche is very close? If a girl has a vaginal discharge, then within 6 months typically, often menarche will happen. So now if you look at from a growth frame, if a girl is 135 centimeters at B2, she is going to land up 155. If she is at B4, she will land up 145. If she already had a menarche, she will land up at 140. So whenever you look at height, always immediately see what the pubertal status is. Look at B2, B4, menarche. That much is good enough from that perspective. What about boys? Now boys, you have to look at testicular volume, and testicular volume of 4 ml using a orchidometer, which is now readily available. You can get it through the website as well. If it is more than 4 ml, entered puberty. More than 10 ml, you will have progression from there, which will be there. Now boys tend to grow a bit later compared to girls, but they have a longer duration of growth. So often they will present to you more likely with what is labeled quote unquote as constitutional delay of puberty and growth. The next important thing to look at is the bone age. Now this is something which is the Achilles heel for most pediatricians because they often find it confusing, difficult, radiologists make a mess of it, and that's why the whole confusion happens. I am not going to talk about bone age in that much detail. We have got a full video for 1 hour on bone age. You can look at my YouTube channel, you can get the information. There's so many resources there. Important thing to remember is that maturation happens from proximal to distal and fusion happens from distal to proximal. So if you have to look at one region to decide about epiphyseal fusion, it will be the distal epiphysis and not carpal bones. Now very often, whenever I go, I ask how do you get bone age, they will say carpal bone +1, -1. There are so many formulas floating around. But the fact of the matter is beyond infancy or 2-year, 3-year, the carpal bones have limited role in terms of evaluation. What you're looking at is the difference between epiphysis and metaphysis. How big is the epiphysis? You will know what your bone age would be from that regards. So in most cases, you have to look at the distal epiphysis. Girls have 3 times higher estrogen than boys even in the prepubertal age group, so their bone age is more advanced, and this is what you're looking at, whether your epiphysis is smaller, equal, bigger or capping. These 4 things you will get the bone age often from that perspective. So epiphysis and metaphysis. So you have to get a full X-ray and often this is cut. This is something absolutely you should say, I want the full hand, especially the distal one, which is important. Finger should be spread and exposure should be proper. There are various ways to go about. This is just a summary slide. What I am trying to say is that in very early age group you can look at carpal bones, but beyond that, most of the area epiphysis size is the most important part to look at in terms of bone age. Now there are ways in which bone age is standardly assessed using the atlases, using the Tanner-Whitehouse method as well as Bone Expert, which provides automated information, but they are time consuming, cost consuming, or there are other issues which are there. So there is a lot of variations, and for pediatricians often this is not very well provided for. So generally when we talk about radiologists, we get reports like 6 to 12 years, 8 to 14 years, and sometimes they will even write no evidence of fracture or rickets, which is a very common report when you send it for bone age. So I have always recommended that maybe they can write bone age is between 0 to 100 years and they will be 100% sensitive specific in that regard. So that's a problem. So that's why we have to look at a good way of assessing bone age in that perspective. So what we have done is that we have tried to develop a simplified way of bone age assessment, in which all you have to do is to compare 5 sites out of 13 sites from Tanner, or maybe 20 sites from the whole carpal already. 5 sites were found to be the best to predict, and when you compare those 5 sites, we found a very high concordance with the gold standard method of Tanner-Whitehouse. And importantly, this resulted in significant time reduction, and even our DNB residents were able to get a very good amount of bone age. So this is a tool which is available. We are currently working on AI based imaging, in which you can just put the image and get the report. The difference at the moment is around 8 months. The main difference within expert users is 5 to 6 months. So once we get to around 6 months, that will be as good as any of the expert to find that. So this is a way we can do the bone age assessment. Now once you have done that, I said that if the child is not short for the family, it is basically familial short stature. If the child is not short for the bone age, that is constitutional delay of puberty and growth. To look at primary causes, you look at the facies, you look at the body proportion, and you can get the right diagnosis from that perspective. Now nutritional versus endocrine is all about weight. If you see a chart like this, in which weight is much more affected compared to height, this is nutritional. If you see a chart like this, in which height is more affected, this is endocrine. But of course there are exceptions which are there, so you have to be cautious. But yes, this will guide your tool. In our study, BMI standard deviation score less than -1 is a marker of nutritional cause. So this is a good objective marker to look at, because we looked at weightage, height age difference, ratio, everything. The best was BMI SDS in that perspective. Now you know that this is a problem. So you have done a growth chart, puberty, bone age assessment. You looked at facies and proportion. You look at birth weight, because birth weight is an important tool, because SGM may not catch up. 80% will catch up by 2 years. Who do not catch up by 2 years to 4 years will usually remain short throughout life. Then very important, if you have a girl with unexplained growth failure, all the workup has been done, do a karyotype, 30-cell karyotype to identify Turner syndrome, which is extremely important. We are now relying more on genetics to identify syndromes, potentially because in many syndromes you should not use growth hormone. They are contraindications. So generally, now recommendations are shifting towards genetics in confusing scenarios from that regards. For skeletal dysplasia, skeletal survey, basic workup for liver, kidney, celiac, TTG is the baseline test, blood gas below 3 years of age. Beyond 3 years of age without polyuria, rickets, I would not recommend blood gas. But of course, if you have rickets, polyuria, you do. But below 3 years, everybody should have a blood gas. And beyond 10 years of age, calprotectin in the feces to identify inflammatory bowel disease is also recommended as part of the protocols. As far as endocrine workup, thyroid for everybody, and I would recommend FT4 as well because you may have central hypothyroidism as well, which Dr. Aisha will talk about in the next session. Growth hormone stimulation test is something which requires a specialized input. A lot of factors are there, so it should be done only after everything has been excluded and an endocrine referral has been sought in that regard. So for everybody, CBC, ALT, creatinine, TTG, FT4, TSH, if needed, karyotype in girls, blood gas below 3 years, calprotectin about 10 years. This is extremely simplistic approach, so to speak, from that perspective. And growth hormone if everything else is normal from that regards. Now, assessment of growth hormone axis, just one message, doing a basal growth hormone is useless. The only indication where I do a basal growth hormone is that when I find that this is very likely to be a growth hormone insensitivity, and then I'll do, okay, they can't afford the test, I'll just do a basal growth hormone, it's very high, that is fine. But otherwise, from a pediatrician's perspective, do not do a basal growth hormone because it's a pulsatile hormone. There are only few pulses in the whole day, every time else it will be 0. So we get so many referrals, growth hormone 0 has start treatment, and that is not recommended. Second thing, it has to be a dynamic test using insulin, glucagon or clonidine. We use clonidine more often, insulin is more complicated in that regards. And remember that you should have a normal cortisol and thyroid axis before you start. One important message is that if you have a prepubertal child, 10 to 12 years of age, 10 years for girls, 11, 12 years for boys, whose predicted height is within the normal range, you may have a confusion that because of lack of testosterone or estrogen, they will have a falsely positive growth hormone stimulation test. So these cases require hormone priming. So what I'm trying to say is that this is not your test, you just write growth hormone test and it is done. It should require a lot of inputs and should ideally be done under somebody who is specialized in that particular area. IGF-1 is a marker which is there, but IGF-1 depends on nutrition. It depends upon liver disease, and less than 5 years it's not very reliable. It's a screening test. So I do, and the reference ranges are also not very good. So I don't recommend a test which is 5,000 rupees, which will tell me then to do a growth hormone stimulation which is again 5,000 rupees. So I think IGF-1 has a very selective role. Routine IGF-1 and BP3 should not be done from a pediatric practice. This will be the message because a lot of interpretatory issues are there. So my question is the child short? If the child is above -2, don't worry, this is normal. Once the child is short, is he short for the family or not? If the height SDS corrected is more than 1.5, this is familial, do not do anything. Next question is the child short for bone age or not? What we do, we plot for the bone age, within the chart the child comes, or our objective criteria is height SDS for bone age more than -2, nothing to be done. Only if the child is short for the population, short for the family, short for the bone age, then your workup starts. So don't write everybody without looking that this is short or not. In that regard, you do workup CBC, ALT, creatinine, electrolytes, TTG. We discussed that. And if these are normal, then you follow up. And only after everything has been done, you look at other causes. Think of Turner syndrome. Think of IgA. Now this is important. Western recommendations say IgA in everybody when you're doing a TTG. that increases the cost, and in our experience the yield is very, very limited. So we do not recommend IGA at the beginning. Maybe you can do it follow-up. If somebody can afford, you can do it right away, TTG and IGA or DGP TTG, that option is there. Only after that you do a growth hormone stimulation test. So message is, go by clinical parameters. 90% you will not need unnecessary workup, but where you require, you need proper expert inputs on that perspective. So what we have tried to do is talked a lot about all that, but once people go off the session, they will forget everything because it becomes complicated. So what we have tried to do is that we have developed a mobile application in which every algorithm that I talked about is there. So all you have to do is just to feed the data. It will automatically analyze the data, give all the SGS scores, and also result in a likely diagnosis and suggested management which will come from that perspective. So you have to put in the data, mother's height, father's height. It will give you the result from that regards, and it's been shown to be highly effective in terms of predicting the height. It is going to give familial short stature or whatever indications all the algorithms are working. So 99% concordance. We are moving a step further by developing a bone age assisted interpretation of growth, in which you have to put in the pubertal status, the basic details, and then you will get information about what's the bone age, what's the interpretation, likely diagnosis, as well as what should be done. So this is something which is going to come up soon, and this is a lot of inputs are there. What we tried to do is that we tried to compare its results with a pediatric trainee, with a pediatrician, with pediatric endocrine trainee, and with a pediatric endocrinologist. And what we found that it could have reduced 96% of discordance. So it is giving you an objective information which is easily making you life easier in terms of guiding, and then of course the decision will be final from that perspective. So now we'll move forward to the next session. Alappan is here and he'll talk about take us through the cases.
Good afternoon everyone. So I'll quickly move on to the cases. The first case, a 12-year-old girl child presented with a height of 132 centimeter and weight of 28 kg. His father height is 164 centimeter and mother's height is 151 centimeter. So Dr. Nitin, I would like to know your approach in this case.
So we will calculate the target height. So
yes. So
target height in this case. So 151 I think, and above 6 centimeter and below 6 centimeter.
Yes.
Of the target height, it will be the range. So this child is falling in the target height range. So it is likely familial short stature. We will calculate the bone age and height age and weight age. Both are 9 years. So it is not showing any pattern of endocrine or nutritional. It is just us, and we will now focus on the growth velocity. So how it is following. If growth velocity is normal, then it is familial short stature only.
So on further follow-up, we have the growth velocity which is around 6 months. The child has gained around 135 centimeter, that is 3.5 centimeter in 6 months.
Yeah.
So do you think this is normal for this child?
It's normal 7 centimeter. It is pre-pubertal. The child is pre-pubertal, so it is normal.
So if we plot this on the growth velocity chart, it's nearly around 50 percentile.
Yeah. So it is normal for this child.
So as sir has already talked about this, that in a short child, you have to first initially see whether the child is really short for the family or not. If the child is in the short for the family, then we have to see for the whether he is short for the bone age or not. In this case, the child is not short for his family. So this is a case of familial short stature, and in this case, there is no further workup is required. Just we have to follow up whether the growth velocity is normal in this child or not. So moving on to the next case, a 13-year-old boy presented with a height of 135 centimeter and weight of 30 kg. His father height is 169 centimeter and mother's height is 56 centimeter. Dr. Utkar sir, I would like to know your opinion regarding this case.
So first and foremost, we will have to plot the weight and height of this child on the growth chart, and we will see what is the height age and weight age of this child. So if we are plotting it, we see that both the weight age and height age are coming approximately at 9.5 years. So both are at the same level. Now, because this is a pre-pubertal child, we will look at the testicular volume to look for the puberty, and it is 3 ml.
Yes, sir.
So obviously this child has not attained the puberty, because we have just learned that at 4 ml of testicular volume, the puberty is attained. So for further assessment,
we did some workup on the screening test, the routine screening test that we do in all the children, like CBC, SGPT, creatinine, TSH and TTC, everything was normal. But we did a basal growth hormone level which was low, and also a growth hormone stimulation test done that is low. I have 2 questions here, whether this basal growth hormone level is at least indicated for this child, and why this growth hormone stimulation test is low for this child.
so first is that we have just been told that basal growth hormone stimulation test should not be done in any case, and growth hormone stimulation test in this patient may be low because the child has not entered the puberty. So there is no pubertal stimulation that has led to a low growth hormone level. So this child should be first primed with testosterone, and then only the growth hormone stimulation test should be done.
Yes, as Sarah rightly said, we have done the priming, and after that we have done the growth hormone stimulation test, and it's showing a peak of growth hormone 15.2, that is normal, in the normal range. And
So
we
we don't
follow
need
up the
to
child in further way, showing there is no growth failure in this child.
So this looks like a constitutional delay.
Yes, sir. So the diagnosis is constitutional delay in puberty, and we should always look for the bone age, the testicular, the pubertal status of the child before considering any pathological cause in the children. Now moving on to the next case, case number 3, a 15-month-old girl child with birth weight of 4,000 gram, 4 kg, LGA child. Mid-parental height is 150 centimeter. She was now having failure to thrive and diagnosed as a case of RTA. Dr. Arpita ma'am, I would like to know your approach in this case.
Okay, so if we look closely at this girl, the birth weight was 4,000 gram, which was very high, or an LGA baby, whereas the MPH was very low for that girl, which was at 150 centimeter in our Indian context. So this is a 15-month-old with large for gestation age at birth, with a normal or average genetic potential. So I would like to know more in detail about the antenatal history. Was the mother diabetic, or was she on any drug? Because we know that the intrauterine growth is dependent on the environment. And there is little effect of the growth hormone and other thyroid and other hormones. So I would like to know the antenatal history, whether the mother was diabetic, leading to macrosomic baby.
Yes, the mother was diabetic, and we further follow up this child.
Okay, so it was actually the normal physiological catch down growth which was occurring. The same thing happens in an SGA baby, where there's a catch up growth till about 2 years. So at 2 years, that switch over occurs, and then the genetic potential, say, the child grows. So this was unnecessary workup of a normal physiology and making it pathological, whereas it was a physiological catch down growth which was occurring in the baby.
So as ma'am has rightly said, the workup was unnecessary. There was some defect in the base axis which we will not consider in this case. This is an IDM child which has a catch down growth. So the practical points regarding this, the size at birth is determined by the fetal environment that is in the maternal womb, and the adult height is predicted by the genetics in the child. So we'll move on to the next case, a 10-year-old girl of height of 120 centimeter, weight of 15 kg, and diagnosed as a case of growth hormone deficiency. Dr. Nitin sir, I would like to know your approach to this case.
So for 10 years, the height is very short and weight is also low. So we will plot the height and weight in the growth chart. So it is showing that weight is more affected than that of height. So weightage is less as compared to height.
And also we have done some investigations.
And those are normal. TTG is also normal. Karyotyping is normal. IGF-1 is low, and basal growth hormone. Here, one important point is that IGF-1 is nutrition and age dependent. So if nutrition is low, malnourished child, then it will give wrong value. And also we are seeing the growth hormone
IgA level. The pretest probability in this child was high. The child was having pallor. He has some growth failure, which is more towards a nutritional failure. The weight was more affected than the height. So the IgA level here in this case was undetectable, and the duodenal biopsy shown villous atrophy.
So it is a case of celiac. And so gluten-free diet will improve the patient. Okay.
So this is a case of a celiac disease, which was mislabeled as growth hormone deficiency, and on improvement of given the gluten-free diet, the child has a significant improvement in terms of his weight, height in that scenario. So now coming on to the next case, an 8-year-old boy of height of 100 centimeter, weight was 18 kg, and now he was diagnosed as a case of celiac disease. Dr. Utkarsh sir, I would like to know your plan of management in this case.
So now this is almost the reverse scenario as the previous case. Here you can see that the height is too much affected as compared to the weight. So if we plot on the growth chart, we see that height is much lagging behind the weight, and the dictum is that if the height age is lower than the weight age, we think of endocrine causes rather than the nutrition causes.
So further investigations?
So the workup is almost normal for this child, and there is obviously no effect of gluten-free diet in this child. So we should.
Sir, would you recommend a growth hormone test in this child?
Yes, in this case, we have to do the endocrine workup, and we have to do the growth hormone test in this child.
So the growth hormone stimulation state we have done, and it's showing a peak value of 1 picogram per ml.
So you have looked at the central cause and found it to be a hypoplastic pituitary.
So this is a case of reverse to the previous case. This is a case of growth hormone deficiency, which has a much more affection on the height portion rather than the weight. And this is a recent guidelines that has been published by Isfahan on the celiac disease. Yeah, sure. Go back.
Basically, the guidelines are suggesting that if you have a high TTG, it's not essential to do a biopsy, because traditionally we have always been saying that you have to do biopsy in everybody. So if your TTG is above 200, 10 times the upper limit, then if your endomycin antibody is positive, biopsy is not required. The second important thing is that if your TTG is between 20 to 200, you do not diagnose celiac unless a biopsy is done. So in that case, biopsy was not done, that was the problem. And the first case which Dr. Nitin talked about, if your TTG is negative, there is a high index of suspicion for celiac, you should do a IgA level in that scenario.
Now moving on to the next case, a 6-year-old boy, height of 90 centimeter and weight of 12 kg, diagnosed as a case of nutritional rickets. He has given multiple doses of vitamin D, X-ray suggestive of rickets. And this is the calcium profile of that child. Dr. Arpita ma'am, I would like to know whether this nutritional ricket, the diagnosis is correct or not.
Okay, so he is a case of rickets. We can see some bony deformity in the form of genuvarum. But here what we have to look is the ALP levels, which are very low for the rickets. For rickets to occur, the ALP should be high and there should be low phosphorus. But here what is the catch point is the ALP is high, and other catch point is that it is a case of refractory rickets. So it points towards some refractory causes of rickets, and we should be further working up this child for the blood gas.
So blood gas has been done and showing this picture in that child.
So there was metabolic acidosis with normal anion gap and positive urine anion gap. So it looks like a case of distal RTA. And okay, the USG-KUB also shows nephrocalcinosis, also favoring distal RTA. And it was predominantly the lower limb involvement. So this looks like a distal artery case.
Okay, thank you, ma'am. Moving on to the next case. So, 14-year-old girl with height of 120 centimeter and weight of 32 kg. It is the this is the picture of that child, girl child, and every profile was done. The routine screening test that we usually do is normal. Dr. Nitin sir, I would like to know how would you like to approach this case?
So, by the picture, it is showing that many clinical features are of Turner syndrome. So, like the webbing of the neck is there, shield-like chest is there, whole hand is not visible, but if we see eyes are closed, the brachymetacarpia, so fourth metacarpal is short, and other features are if eyes have some ptosis, some nevi, in the face you will find some nevi, the squint is also there in eyes. So these are the clinical pointers which shows the Turner may be there. So what was the FSH level?
So FSH level was high in this child.
FSH was high for 14 years. So it is in the menopausal range. So we will, in spite of FSH high and showing the clinical features of Turner, we must do karyotype, because if there is some Y cell line in that,
.1 kg, having a poor growth but a normal development. Height is right now 90 centimeter, weight of 10 kg. This is the growth chart of that child. And Dr. Utkarsh sir, I would like to know how would you like to plan on this case?
So this is the SGA child, and in these patients we usually expect to have a catch-up growth by about 2 years. If not at 4 years, it will not be so. So we have to follow this child.
Yes.
So usually if they are having quite lot of catch-up growth, there can be some metabolic associations. So we have heard about the Walker's hypothesis. So if SGA babies grow too much, there is a problem. So we should always tell their parents that they should be growing slowly initially. And this is the growth maximum growth catch-up which is showing in these children. Many of them will catch up in the first year only.
So we should always go slow with the SGA children. They have a much more propensity to develop metabolic complications like type 2 diabetes, and also having an increased chance of precocious puberty if there is a rapid catch-up weight gain in the initial phases. Now, moving on to the next case, a 10-year-old girl child, height of 112 centimeter and weight of 24 kg. You can see the child here, and a normal investigation was done. So, Dr. Arpita ma'am, I would like to know any further workup, any further anthropometric measurement you want to know in this child.
Okay, so before going further into the investigation, we have to follow the basics. We have to plot the growth parameters of the child in the growth chart and do a adequate anthropometry. So in this child we can see there are some bony deformities in the lower limb, and the upper segment and the lower segment seems to be disproportionate, with the upper segment higher. At 10 years of age, it should be equal. So what was the upper segment and the lower segment? It was higher.
Higher, yes.
So it points towards certain genetic causes of skeletal dysplasia, probably achondroplasia or hypochondroplasia. So we can go for a mutation in FGF24 gene.
Yes, so this is a case of achondroplasia having a mutation in the FGFR gene. And we should always remember to look for the upper segment lower segment ratio in that scenario. Now moving on to the next case, a 16-year-old boy of height of 167.5 centimeter and weight of 127 kg.
So we have discussed about the part with regards to the growth issues. Now we'll talk a bit about obesity, which is becoming much more common. Now, as compared to short stature, where I said 80% are physiological, 98% of obesity are actually physiological. Only 2% will have a pathological cause. So if a child has got normal growth, development and puberty, it is unlikely to have a pathological cause. So just look at these three things. If, however, there is hyperphagia, early onset before 2 to 5 years of age, vision abnormality, think of a genetic causes of obesity. You also have to think of drugs. So the drugs which we commonly know, of course, are steroids, but valproic acid also causes significant weight gain. So you have to be very cautious in terms of drug-induced obesity. And endocrine causes have growth and pubertal as a primary pathology. So what you need to look at is the child obese or not? If the child's age is less than 5 years and growth is too much, we use weight for height SDS / in this protocol, it's written BMI SDS, then you think of a genetic cause. Otherwise, you go for development, vision and dysmorphism, and if it is there, think of a genetic cause, otherwise go ahead in terms of workup. So you have to be careful in that perspective. So the most important thing to look at in an obese child is the height. The most important thing to look at in a short child is the weight. Most important thing to look at in an obese child is the height. If they are tall, this is endocrine. This is non-endocrine, this is nutritional. If they are short, this is endocrine. Short and plump is endocrine. And again, as I said, we have developed obesity interpreter, which provides high level of concordance in that regard. So you can now take over from the cases.
12-year-old boy presented with obesity. Height is 160 centimeter, weight is 70 kg. Someone did a thyroid profile for the routine screening and TSH was mildly borderline elevated, 7.91, and he was advised thyroxine in this scenario. Dr. Nitin sir, I would like to know whether you are agreeing to the thyroid management in this case. clear, that is the hyperphagia is present or not, segregating, that is family history is present or not, and syndromic. In this condition, one should always look for any syndromic association in case of obesity. Thank you.
So I think what all of you can do now is that while the distribution starts, we can quickly scan the QR code. And I think Prashantji, you've got the sheets you can share to them. And this will take you directly to the quiz. There are 15 questions in the quiz. And if you will give 10 minutes around for the quiz to answer. And then you can easily go from there. And we've got very attractive this for all the categories. We've got 2 categories for postgraduates as well as for the trainees. So I think if you can use this to scan, and alternatively the sheets are being circulated as well.
Good afternoon. Post-lunch session, it was very enlightening and very ground-to-earth presentation, and very useful in day-to-day practice. If anybody wants to ask some question. Yes. Because this was very important day-to-day scenario.
Hello. So the question is not pertaining to this particular talk, but when you talked of growth hormone being pulsatile, so I like to know in endocrinology practice, which hormones have this tendency of being pulsatile? What are the special ways of collecting these hormones? What is these pool samples or unpooled samples? And how do we really go about when investigating these hormones?
Yes, very, very important question. So many times we have got pulsatility problem which is there. For things like LH, FSH, cortisol, prolactin, you do have these problems happening. So what we say is that you take pooled sample of 3 samples, you take 0, 15 and 30 minutes and mix them up and then run as a single test. So it's not that you're looking at 0 separately, 15 separately, 30 minutes separately. You take 3 samples and pool them up to get the idea. So this is one way of cutting down on pulsatility. The other way is to use either dynamic test, whether you can use a stimulation test or a suppression test. So the dictum is that if you are thinking of deficiency, you stimulate, like growth hormone stimulation test. If you're looking at excess, you suppress, like adrenal overnight DEXA suppression test which you wanted to do. So, and the other way around is that if you have a very labile hormone which is fluctuating, you can't measure it easily, like insulin, then you don't measure insulin, you measure a correlate of insulin, which is C-peptide. If you want to measure arginine vasopressin, you cannot do because it's a very short half-life. You do another hormone which is copeptin, which can be measured. So there are ways in which, so you need to be very clear that for this condition, this is the right test to choose. This is the right way to go forward from that perspective.
PTH?
Yes, so PTH doesn't have that much pulsatility issue, but it's a very, very thermolabile hormone which we discussed in the calcium session. So PTH should be taken immediately processed, or you transport it in the ice. Otherwise the PTH levels will be low and you will not be able to make an idea on that. Similarly, insulin, renin activity and many other hormones like that may have problems in terms of transport, which becomes important. And the other big thing when you're talking about that is to always interpret hormones in response to their feedback response. So when you're looking at TSH level, look at what the FT4 level is. If you're looking at PTH, look at what the calcium level is. If you're looking at insulin, look at the glucose level, because then only you can make some sense in terms of the right idea.
Thank you.
Thank you.
So we are running the test, and so there are prizes. So I think we should not tell others the answers if you want to really win from that regard. So that is the thing. The 10 minutes, so I think we'll wait for another 5 minutes, 7 minutes. Yeah.
Now I would like to invite our next speaker, Professor Aisha Ahmed Mam from Aligarh Muslim University Department of Pediatrics for the next session on thyroid disorders. The chairperson for this session are Dr. A.C. Chawla sir, Dr. Ajay Srivastav sir, and the panelist for this session is Dr. Alappan, Dr. Nitin, and Aisha ma'am will also join after the talk. I would request the chairpersons to kindly introduce Dr. Aisha ma'am.
Good afternoon, and first of all I wish to thank Dr. Arpita and team for conducting such a nice program, and especially Dr. Anurag Vajpayee. You are simply the doyen of pediatric endocrinology of all over India. And now I welcome our speaker, Dr. Aisha Ahmed. She is faculty in Department of Pediatrics, Jain Medical College, Aligarh Muslim University, and she is ESP Fellow, Pediatric Endocrinology, University of Newcastle, UK, and ISPAD Fellow, Pediatric Diabetes, Barbara Davis Center for Diabetes, Colorado, US. So welcome you, ma'am.
Thank you so much. So I think we'll wait for 5 minutes before the quiz is over. ठीक है.
So we've got 2 more minutes to go. So those who are finishing can finish in the next 2 minutes. Then we'll start with the session. please submit the response as soon as possible, and Dr. Aisha, kindly go ahead, please. Thank you.
Okay, so good afternoon, everyone. So I welcome you all to the next session on thyroid module, and I agree, after the post-lunch session, it is very challenging task to keep all of you awake, but you are no exception because we all are sailing in the same boat. So before we move to the case-based discussions, a quick recap of the physiology of how thyroid gland works. So actually what happens, it starts from the hypothalamus, where thyrotropin releasing hormone from the hypothalamus, it acts on the receptors and stimulates production of TSH from the pituitary gland, which again acts on the main gland, that is thyroid hormone, thyroid gland, to cause production of thyroid hormone. The main thyroid hormone, as you all are aware, is the T4, and which in periphery is converted into the T3, which is the more physiological hormone, and this action is brought about by thyroid just deiodinase. So this thyroid hormone, most of the thyroid hormone is present in the circulation, bound to thyroid binding globulins, and only a very minimal percentage of hormone is present in the free form. About just 0.03% of thyroid hormone is present in the circulation as a free form, while most of that is bound to TBGs. And same for T3. So it's only 0.3% of T3 which is present in the free form, which is the hormone available for its physiological action to take place, which acts on the different receptors for its action to take place. So what happens in case of hypothyroidism? So first hormone, the first biochemical abnormality that can be detected is increase in the TSH. Is it working? Okay. So increase in the TSH followed by decrease in the concentration of T4, thyroid hormones, and this is followed by the fall in the T3. The reason being that still even when there is hypothyroidism, so this, because of peripheral conversion of T4 into T3, there is a delayed fall in T3. So therefore T3 is not a very good hormone for checking in cases of hypothyroidism. Whereas in cases of like where there is decrease in the thyroid hormones, but the TSH levels, they are either it's normal or it's inappropriately normal for that low level of thyroid hormone, then this is a condition where you should suspect central hypothyroidism. So if the decrease in T4 and in a later way, late stages T3, or in, with a concomitant increase in TSH, always suspect primary hypothyroidism, whereas in the situations where TSH is not increased or normal, inappropriately normal, so this is the condition where you suspect central hypothyroidism. So, and what happens in case, again, if the TSH levels are, there is fall in levels of TSH along with followed by a rise in T4 levels. So this is a condition which is the opposite of what I talked about. So this is a condition where you suspect hyperthyroidism or thyrotoxicosis. And in case of, like if you talk about T3, so in cases of hyperthyroidism, definitely T3 is a good biochemical parameter to be relied upon. So how do you interpret what are thyroid function tests? So in cases of hypofunctioning thyroid gland, so as I said, there will be initial rise in TSH followed by reduction in the level of T4 levels, and in the later stages reduction in T3. And why later stages? Because still there will be conversion of T4 to T3, so level would be maintained for a prolonged period of time. So this is a situation which is hypothyroidism. So that calls that you, for evaluating a child in suspected hypothyroidisms, if there are hormones or biochemical parameters which are of use, then that is TSH and free T4 levels. Whereas in cases of hyperfunctioning thyroid gland, so there will be reduction, the earliest reduction in the TSH followed by increase in the level of T4 and also level of T3. So in cases of suspected thyrotoxicosis or thyroid gland working overtly on the higher side, so you have the hormones would be TSH and T4 along with T3 levels. So as it was being discussed, like many other hormones, endocrine hormones, thyroid hormone secretion and TSH is also no exception. So it does not, it is definitely being continuously secreted, but the levels are changing. So it's not being secreted in a steady state.
Hello.
So you have to keep this thing in mind that there is variation in the TSH secretion in a 24-hour period. So it's about to the tune of 40 to 50%, and can be intra-observer as well as inter-observer variability also. So while interpreting this TSH level, these things have to be kept in mind. So now the most important aspect about TSH is about the neonatal TSH concentration and how to interpret a newborn with a suspected hypothyroidism. So whenever a baby is born, so there is initial surge, and this surge takes about 30 minutes to 1 hour after birth. So there is an increased normal physiological surge in newborn's blood, and this surge can remain till 22 hours of life. So this is the reason why if you have to, and the same thing happens, we can see in this chart, the same thing happens in prematures always, in the same manner, albeit at a lower intensity. So the same thing would happen, so there will be initial physiological rise in TSH levels, which comes back to normal in 72 hours. The reason, the implication of that is, whenever you have to check for hypothyroidism, either it should be done in the cord blood before this TSH surge happens, or it should be done after 72 hours. Always before you, you can firstly label the child on newborn as and if there is a situation that this TSH has to be checked within the 24 to 48 hours of life, then you have to take a higher levels as compared to after 72 hours, and I will come to it in a short while. So depending upon the age, this chart shows what is the upper limit and what is the limit at which action has to be taken. So if you can see, the levels in the first week of life is 20 millinternational units per liter. So this is the time where you suspect and start thinking that something has to be done in further investigation. And action means the treatment. This level shows that irrespective of the investigations, they have to be started, but the treatment has to be started. The reason being, for congenital hypothyroidism, if you don't treat in 2 weeks' time, then definitely there will be chances of having severe cognitive impairment. So the treatment has to be started, and you should not wait for that for the amount of investigations. So talking about how to interpret, so the same thing, so you can see there is inverse relationship between the hormone and the stimulatory hormone. So in situation where the free T4 levels are low and the TSH levels are high, so what does that indicate? Obviously, T4 levels low, TSH levels above 20. So this would be suspected, the condition would be primary hypothyroidism. Quite obvious. But if the levels are TSH are low, like for in a simple primary hypothyroidism, what you expect, that is the free T4 levels are low, because as I said, the stimulatory hormone would be high just to bring back the thyroid hormone levels to normal levels. But if the levels are below 20, it will increase, but inappropriately normal, not increase to the level that you would suspect in the case of primary hypothyroidism. So this is the situation where you would suspect central hypothyroidism. And in the opposite extreme, what happens if the levels of free T4 are high and the levels of TSH are low? Levels are low or undetectable, so this will be a condition of thyrotoxicosis. T4 levels are high and the TSH levels are undetectable. But if the situation is TSH levels are high, both T4 as well as the TSH levels are high, then this is the condition of TSH adenoma. So simply just two biochemical parameters would help you to arrive at a diagnosis whether this is a primary hypothyroidism, defect is at the just thyroid gland level, or it's at the high level like pituitary or hypothalamus level. So how do you interpret in this chart? So first thing you have to look at while interpreting TFT is look at the level of TSH, and based on T4 levels, this is the repetition of the same thing. Like if the levels are low, so you have to look at the free T4 levels. If the levels are low, so that goes in favor of central low, normal, or inappropriately normal or low, so that goes in favor of central hypothyroidism. But if the levels are high, so thyrotoxicosis, and if the levels are normal, so T3 toxicosis. So talking about neonatal screening at day 3, as I said, it should always be done either from the cord blood or at day 3 of life. So there are certain situations where even this checking or screening at T3 might not detect cases of hypothyroidism. So what are those conditions which warrant a re-screening? Okay, so they have to be re-screened after 2 weeks. This happens in premature babies because they have at times a delayed rise in TSH. So you might miss hypothyroidism if you screen them only at 72 hours of life. So they warrant screening again at 2 weeks of life in cases of trisomy 21. In cases of same-sex twins, and also in cases in babies who are sick. So in these situations, you always have to reassess the thyroid TFTs after 2 weeks. So this again chart shows the same thing. So just remember two values 20 and 40. So if the child during your screening has levels less than 20, so this you have to just reassure nothing has to be done. If the levels are borderline between 20 to 40, it has to be repeated after 14 days. And if the levels are more above 40, so then you have to start treatment. Investigation will go hand in hand, but the treatment has to be started. And again the same thing, after 14 days, again you have to check if the levels are less than 10. So less than 2 weeks, it's 20. More than 2 weeks, if you can say, just remember the value 10. So if it's less than 10, no treatment, it's normal, no treatment has to be started. If it's more than 20, treatment has to be started. So it's 40 and 20, less than 2 weeks and more than 2 weeks. And re-screening, always remember, even if the first screening is normal, so then is these conditions, you always have to re-screen the baby after 2 weeks. So what happens in a preterm? So once you do TSH at 24 to 48 hours of life, if the levels are less than 10, the same situation, repeat, because this is the preterm baby, has to be repeated at a later date or when the baby is at term. If it's more than 10, then you have to look at free T4 levels and TSH levels. If it's low free T4 or TSH is above, one of these above 10, then it's primary CH and treatment has to be started. If the scenario is T4 levels are normal with the TSH of less than 10, it has again to be repeated. And if TSH levels are 10, then again you have to look for free T4 levels if the levels are low and the baby has other features of multiple pituitary hormone like microphallus, like midline central abnormalities, okay, like cryptorchidism, then you have to if the answer is yes, he has certain other features like hypoglycemia, features of MPHD, then it has to be suspect a case of congenital hypothyroidism. And this again, you have to subject the baby to MRI and the treatment has to be started. If it's not the case, look at free T4 levels. If it's normal, again has to be repeated because there might be delayed rise in TSH. If it's low, then it's a central cause of hypothyroidism and treatment has to be started. Okay. So how do we approach? So talking about the imaging, where imaging fits in while managing a child with CH. So it might detect ectopic thyroid gland. It might, this intake would be the scan, the radio tracer uptake would be increased in conditions like dysharmogenesis and iodine deficiency, whereas it can be absent. So if it does not show any increased uptake, then second line would be always a thyroid ultrasound. So if it's absent, it denotes there is agenesis, absence of thyroid gland. If it's present, then you have to look for receptor antibodies. If the antibodies are present, you have to check for antibody levels in the mother. If they're absent, then you have to, this might be a case of sodium iodide symporter defect or genetic analysis has to be done to confirm the etiology. So this investigation is done just to ascertain the etiology of hypothyroidism. So I think we'll start with the case. So Dr. Sandeep, you will take it from here? Okay. So we'll take this. You want this printer?
Thank you.
Alappan, Dr. Nitin Pandey, and Professor Aisha ma'am. And I would request Dr. Sandeep to take forward the
Thank you,
case
ma'am.
presentation.
Thank you, ma'am, for the wonderful lecture, ma'am. So this is a 20 years old girl, and at 20 years the TSH was 28. So what will be the plan? Dr. Aisha, ma'am, since the age is 20 years only, with this TSH, what will be the plan, ma'am?
Okay, so can I have answer from the audience, students? Okay. If you look at the age, this is a 20 hours old girl, and the TSH levels looks high. The figure I told you, 20, 40, sample too early. Okay. So Sarah has rightly given the answer. So always, before interpreting a thyroid function test, always look at the baby at what age, hours of life the test was drawn. So if you can see, so either it should be done soon after birth from the cord, or it should be done at 72 hours. And if at all it has to be done within the 24 to 48 hours, then the levels are high, it's around 34 milli-international units.
So the repeat test in this patient was within normal.
Within normal limits.
So the key message is that screening should be done either with the cord blood or after 72 hours when the TSH surge is settled down. And if you are doing between 48 to 72 hours, the cutoff is 34. Day 4 child, the TSH is 22, and again at 2 weeks it is 12, and 21 days it is 9. But the FT4 was normal. So Dr. Nitin, what will be your approach?
So according to algorithm, if we go week 3, third week, if it is in the range of 6 to 20, then we have to do scanning. So at the algorithm, the center one, the third, fourth square, it is showing if it is in the 6 to 20 milli-unit per liter, then we have to repeat the FT4 and do the scan. So we will do scan, and we found that hemiagenesis was there. So we have to continue the treatment.
Okay. Thank you very much, sir. Okay. So the key message is that after 3 weeks, if TSH is between 6 to 20, then it is a matter of concern, and we should do the further investigations and if required treatment. Day 10, TSH is more than 100, FT4 11. On scan, there was no thyroid tissue. So what will be the plan? Dr. Alappan?
So this is a day 10 child with a high TSH level and a low FT4 level. So this is a clear-cut case of congenital hypothyroidism. Now, as per the adults where there is a availability of T3 Lenormand, we don't have much more options here. We can go for the only thyroxine, levothyroxine in this treatment. The only dictum of this congenital hypothyroidism is hit harder and hit early. So we have to start with a higher doses like 10 to 15 microgram per kg per day. But as we all know, the severity of congenital hypothyroidism though depends on the TSH level, the neurocognitive function in the infancy depends on the FT4 level. So we will titrate the dose in this child, and as we can see in this case, the FT4 level is not so low, around 11. So we can start with a bit lower dose like 10 to 12 microgram per kg per day. Regarding the administration of the thyroid in newborns and infants, there is no fixed timing that we have to give it in empty stomach. So we can give the tablet in crushing using breast milk, and also the best approach is to give in after 4 hours of a feed, but we can give it to any time to the children. Now coming to the next point, the etiology. So we can see here that the thyroid scan is showing no uptake. So two major differentials are out here. One is ectopic thyroid, that is rule out, and another is some dysharmonogenesis which is showing increased uptake. So two major group of disorders are remaining where there is no uptake. We can't surely say that there is no thyroid gland present. So when there is no uptake in the thyroid scan, we should always look for the thyroid USG. In thyroid USG, if it is present, the gland is present, we can say this is a condition is apparent athyrosis. That means thyroid is not uptaking, but still gland is present. Only 3 or 4 differential are there. One is NIS defect, one is TSH receptor defect, and we have to ask for the maternal thyroid status, so that sometimes the maternal antibody comes to the baby and causes blockage of the uptake of the scan. So in this case, I would like to know the USG status, whether the gland is present or not in this scenario.
So in this patient, the gland was present on USG. So the trap were done and trap receptors were, TSH receptor antibodies was present.
So probably the maternal antibody has transferred via placenta and goes to the baby, causing this thing. And this is not a case of agenesis. So we can continue the treatment and we can have a trial around 3 years of age to see whether there is really reversal of this condition or not.
So the key message is that all absent uptakes are not agenesis. So we have to do ultrasound to look for true and apparent atheriosis. Day 4, a TSH is 100, labeled as dysharmonogenesis, started on levothyroxine. At 4 weeks, the FT4 is 21 and TSH is 24. So, Dr. Ayesha ma'am.
So now the child has been started on treatment. As you can see, after 4 weeks, the T4 levels have become normal, but TSH is still on the higher side. So what has to be done? So dose is very important, as very rightly pointed out by Dr. Alapan. You have to treat and bring back the T4, free T4 levels as early as possible, because just to take care of the neurocognitive impairment. So you have to, the doses, if you can see, are higher as compared to the other children. The T4 levels have to be brought down at early stage, so you have to hit hard and hit early, as very rightly pointed out. So dose has to be titrated, so you have to start the dose at a higher dose per kg weight, and it has to be monitored like 2 weekly till TSH level. So TSH would take time to come back to normal, so don't just chase the TSH values. So it has to be done every 2 weeks. After once the TSH becomes normalized, then it has to be done every monthly for the first year of life. And whenever you make changes in any dose, so it has to be checked 6 to 8 weeks after making the dose changes. So the target has to be, the FT4 has to be brought back to the target as early as possible. TSH would follow. So you have to wait for 6 to 8 weeks after once you start the child on treatment.
So as ma'am has correctly said that in this patient the T4 was in the higher limit, but the TSH was also high. So we have to continue the same treatment.
And you have to always check for compliance, whether the drug is being given in proper dosage and properly daily or not.
So in this patient there was a speech delay at 3 years of age. So Dr. Nitin, what?
So we should find out the other associations. Hearing assessment should be done, because the Pendred syndrome rarely may be associated with the thyroid problem, because Pendred gene is responsible for hearing also and thyroid synthesis also, thyroid hormone. So, and also along with that, development and epiphyseal dysgenesis, these are also associations we should check. Okay.
Thank you, sir. So the key message is that hypothalamic pituitary thyroid axis takes time to settle. So the initial titration has to be done with the T4 levels. And hearing assessment is very crucial. 32 weeks neonate, on routine screening the TSH was 7 and the free T4 was normal. So Dr. Alapan, what will be the approach?
So this topic has been elaborately covered by ma'am in the lecture session. So this is a 32-week neonate of TSH of around 7 with a normal FT4 level. Now we have to always remember this thing, that in a preterm child the TSH values are a bit lower from the term children, as well as there was delayed rise of TSH. So in comparison to the term children where less than 20 we don't need any follow up, we can discharge the child. Here we have to follow up the child at least after 2 to 4 weeks to see whether there is any delayed rise present or not. Sometimes if we do not do this follow up, we may miss the chances of detecting primary congenital hypothyroidism in that scenario. So I want to know the repeat value, that is 14 right now.
At 2 weeks TSH was 14.
Yes, so this is clearly showing above the level of 10. So it is a delayed rise, and we may further follow up the child. We can see the FT4 level and see whether the child could be treated or not in that scenario.
Thank you, Dr. Alapan. So the key message is that in preterm babies there is a delayed rise. So there should be a repeat screen after 2 weeks. We should.
So coming back to hypothyroidism, so apart from the usual complaints like whatever we see a child who has hypothyroidism, what the major complaint the parents have is the child is not growing, height is low and the weight is high. Weight is going on the higher side and the decreased scholastic performance. So you should always think of hypothyroidism in a child who is not gaining height as required for his or her age. The child who has pubertal disorders, always remember both kinds of disorders of puberty, both delayed puberty as well as precocious puberty can be seen in children with undiagnosed hypothyroidism. In children who present with cardiomyopathies, in hyponatremia, so these are conditions where there might be underlying hypothyroidism as the cause, a child who has motor delay, and in cases of hyperandrogenism. So in these conditions, always suspect and think about underlying hypothyroidism. In a child who has fatigability, who has worsening of school performance, mostly the parents have this complaint that the child's performance is reduced, and emotional lability. So the investigations would be, if you check for the lipid profile, so you may have low LDL and high HDL levels. There might be high CPK, prolactins, there might be anemia which can be macrocytic, and hyponatremia. So in these conditions, always suspect hypothyroidism. So how do you approach a case of hypothyroidism? So you look at the free T4 levels. If the levels are low, you have to look at TSH levels. If the levels are above 20, so this is a case of primary hypothyroidism. If the levels are below, which is inappropriately normal for a child or normal, so always suspect central cause of hypothyroidism, and you have to get one MRI and also the cortisol levels done if there are features of, there can be involvement of other anterior pituitary gland hormones also. Whereas in situation where the TSH levels are normal, if the TSH, you have to look for risk factors. So this calls for T4 levels are normal, but the TSH levels are high. So what does that indicate? T4 levels are normal, but TSH is on the higher side. So this could be subclinical hypothyroidism. So if the levels are below 6, so nothing has to be done, this is normal. But if the levels are in between, subclinical, TSH is borderline high, but the T4 levels are normal. So whether to treat or not. So there are certain risk factors where children with subclinical hypothyroidism need to be treated. So what are those? If there is autoimmunity, if the child is TPO positive, if there is presence of goiter, or if the child is not gaining height well. So these are, if there is family history of a strong family history of hypothyroidism and in a female child. So these are the conditions where you should treat a child with subclinical hypothyroidism as well. So how do you start the dose? So as I said, for neonatal period, the doses are high as compared to the rest of the pediatric age group. So based on the age of the child, so this is just a starting point. You have to start based on either body surface area or per kg body weight. And again, then you keep monitoring the TSH levels and T4 levels, and then you can always titrate the dose accordingly. And this has to be done after 6 to 8 weeks of starting the dose. So it can be started both ways. Just remember that in subclinical hypothyroidism, so for newborns, you start on a higher dose because you have to bring back this T4 levels as quickly as possible. Whereas in conditions of severe cases like prolonged untreated hypothyroidism, always remember you have to start the treatment at a very low dose, and also in cases of subclinical hypothyroidism, and gradually you always have to build up the dose. So don't rush in like in cases of hyponatremia or any other chronic condition. So similarly, that holds true for prolonged untreated hypothyroidism also, that you have to start very slow and gradually build up the dose. So there can be interference. Whenever you tell, so what we always follow is we tell them to take the drug empty stomach in the morning, and there can be interference with calcium, iron, because very common, the child may be anemic. The complaints with the parents have is the child is not growing well, irritability, the child, so always they are started on some supplements or the other. So there might be interference, so it should never be given with these calcium and iron supplementations. Also with soy proteins, the soy milk and light. So these precautions should always be taken into consideration while whenever you start a child on hypothyroidism. So again, I would go back to a case. So.
Thank you. In this case, the girl is 12 years old and she is a case of obesity. Height is 156 centimeter, weight is 56 kgs. There were no clinical features of hypothyroidism. TSH was found to be high, it was 6.4. And she was advised thyroxine treatment. So Dr. Aisha ma'am, what
So
will be your
again,
approach?
again a very common scenario and which was very nicely dealt with in the last session. The child has weight on the higher side, obese child, and the TSH is borderline. So if you can go back to the chart. So just always remember these children do not warrant treatment because this increase in this TSH, borderline TSH is the effect of obesity and not the cause of obesity. Because most of the parents, they feel the weight gain the child has is because of TSH, because of hypothyroidism, but that is very unusually the case. Okay, so because of the increase in the leptin levels in obese individual, which has stimulatory effect on TRH, which leads to elevation of TSH. So until unless it's very high, like more than 10, then definitely you'll have to think of hypothyroidism. Otherwise, in obese children having TSH in the borderline range, do not start them on treatment. So that is the take-home message from this side.
This patient was not having any goiter. No pictures of hypothyroidism. T4 was normal, TP was negative. So it was effect of obesity. The high TSH was effect of obesity, not the cause. And there is no treatment required if the TSH is below 10. It's working. A 10-year-old girl, she had poor concentration. She had poor concentration. Height was 136, weight 34 kg. She was euthyroid, TSH 2.4, and total T4 was 60. So what will be the plan, Dr. Nitin sir?
So actually the total T4 value may bias sometimes. So for the correct diagnosis, we should order the free T4. And if we are ordering total T4, albumin level should also be ordered. So free T4 here, it is normal. It is normal. TSH is also normal. So it is not the cause of the poor scholastic performance. Hypothyroidism is not the feature here. So TPO is also negative. No treatment is advised.
A 12-year-old girl, she had lethargy, height was 140 centimeters, weight 36 kgs, free T4 was low, 6, TSH was 12, and she was started on thyroxine. So Dr. Alappan, what do you think? What can be the diagnosis?
So the hormonal assessment should always be contextual. That means if you have interpreting the insulin level, we should always see the glucose level. If you are interpreting the PTH level, we should always interpret in the light of calcium. Like here, we should always interpret the TSH level on the basis of the FT4 level. If FT4 level is low, the TSH should be much higher. It should be more than 100 or something like that. If it is less than 20, we should always have the possibility of central hypothyroidism in that scenario. And in central hypothyroidism, it is very unlikely to have isolated thyroid deficiency. So we should always check for the other anterior pituitary hormones like prolactin, like cortisol in that scenario. So I would like to know the other anterior pituitary hormone deficiencies, whether present or not.
The cortisol level was low and the MRI was suggestive of empty cella.
So the cortisol level is, as you can see, this is low. And one more important thing here, that if you start in the central hypothyroidism, you also give the thyroxine. In the primary hypothyroidism, you also give thyroxine. Maybe central we give a much lower dose. But what is the problem? If we start thyroxine before replacing the hydrocortisone or cortisol, the thyroxine will increase the metabolism of cortisol, further can lead to a crisis-like condition. So we should always start with the hydrocortisone replacement. 1 week or 2 weeks later, we can start with the thyroid with a lower dose in that scenario. So this is a case of central hypothyroidism, probably an MPHD in that scenario.
Thank you, Dr. Alappan. So the key message, when there is low T4 and TSH is below 20, then we should always suspect central. And in that case, we should look for the other hormones and we should go for imaging. 12-year-old girl, she had growth failure, TSH was 100, more than 100, T4 was low. So Dr. Aisha ma'am, Yes, ma'am.
Children in cases of subclinical and children in whom diagnosis has been established after a later time, like prolonged untreated. So always, as I said, it has to be started slow and you have to gradually titrate up the dose. Okay, like 25%, 30% you can increase in a week, 10 days time. And always check for interference, whether the child is not taking any other drug which might affect the absorption of thyroxine tablets.
Thank you, ma'am. So this patient on follow-up after 1 year, the TSH was 24 and free T4 was again found to be high, 26. So what will be the plan or what will be the interpretation? Dr. Alapan?
So on follow-up, we can see there is a high free T4 level and TSH level. So we know there are major two hormones. One is T4 and one is T3. The T4 is produced from the gland. T3 is majorly the peripheral conversion. But there is 20% of T3 which is coming from the gland. So in this scenario, if we have to keep the T3 level maintained in our body, we should have the T4 level on the upper limit of the higher normal range. But here we can see that T4 level is much higher. So that means that maybe that T4 has given much from the outside. T4 level is high. But the major discrepancy here is, even if the T4 level is high, the TSH is not suppressed. That means that the TSH level is the cumulative dose of T4 in the previous few weeks that determines the TSH level actually. So probably this child had missed some doses. That's the reason there is increase in the TSH level. But followed after that, when he come to us or when he come for the treatment, come for the test, he has taken some thyroxine leading to a FT4 rest and TSH rest like syndrome. So we always have to see for the adherence, whether patient is compliant or not, whether he is taking the drug properly, whether he is taking the drug in the empty stomach, whether he is taking the drug without any calcium, antacids or any other iron in that scenario.
Thank you, Dr. Alapan. So the key message that there should be a gradual displacement in severe cases and subclinical cases. The timing is very important, half an hour before meals or after 4 hours after meal, and at least 8 hours difference between the calcium and iron containing tablets. Adherence is very important, so it has to be taken daily and then only will come to a good control. So this is a 10 years old, sir, anything you want to add? 6 years old boy, there was meningitis, the TSH was found to be low and free T4 was 6. So Dr. Nathan, what do you think in this sick child?
So here free T4 is low and TSH is less than 20. So picture is looking like central hypothyroidism, but it is a sick baby, and in sick baby mostly we are advised that we should not do thyroid function test. But if there is strong suspicion of thyroid derangement in sick child, then we should also do cortisol along with that. And if it is low, then we should think of central MPSD like picture. And if it is normal, then it is just a non-thyroidal illness.
So as correctly said, it was the cortisol was 760 and it was non-thyroidal illness, and it has to be, the TSH has to be repeated after 4 to 6 weeks.
So now moving on to the other extreme of hyperfunctioning thyroid gland. So thyrotoxicosis. So when should you suspect thyrotoxicosis? In a child who has a recent weight loss, hyperdefecation in a child who presents with tremors, who has eye signs, periodic paralysis and polyuria. So in these conditions, always suspect there might be a hyperfunctioning thyroid gland. So how do you approach, like in cases of hypo, so how do you approach a case of hyperfunctioning thyroid? So in a child who has these features, you subject the child to nuclear scanning. So what happens if there is decreased uptake, so and if there is associated tenderness also, so it might be a case of subacute thyroiditis, and it's not, it could be a case of chronic lymphocytic or autoimmune hyperfunctioning hyperthyroidism. In case of increased uptake, it could be solitary, depending upon how much and how defined the uptake has been. whether it is diffuse or it's just localized. So it could be a solitary nodule, it could be a toxic MNG, or it could be a Graves' disease, which again warrants a antibody panel. So again, we move on to the case.
12 days old child presented with irritability. Birth weight was 2.8 and presently 2.2 kgs. The heart rate was 168, there was proptosis. Free T4 was 44 and the TSH was less than 0.001. Mother had Graves' disease and she underwent radioactive iodine 2 years ago. So Dr. Ayesha ma'am, what is the scenario?
So as you can see, that's what I talked about. This baby has a significant weight loss, has tachycardia, has eye signs, and the biochemical, the TFT shows a free T4 levels, which is in the higher side with the suppressed TSH levels. So whenever you suspect, and in newborns in any situation, you should always take a detailed maternal history. So going by that, it was seen that mother had hyperthyroidism and she had received radioactive ablation for that. So always remember, these things might take time. No matter if the mother has become euthyroid, but if she has taken a treatment, the antibody, the stimulating antibodies might remain in her body for a long period of time, for weeks altogether. And this antibody can very well cross through placenta and cause hyperthyroidism in the newborn per se. So maybe even if the mother has taken treatment for that, you have to check the newborn for presence of antibody levels, and you have to take the remedial measures accordingly. So the treatment, because it can persist for about 6 to 8 weeks, for months altogether. So the treatment, if the child has symptoms and the biochemical parameter like this newborn showing hyperthyroidism, so you have to give antithyroid drugs and might require beta blocker for taking care of this sympathetic hyperactivity, and also for reducing the conversion of T4 into T3, and steroids. So depending upon the status, whether he is in crisis or simple just hyperthyroidism, so treatment has to be started definitely, because it's another case of neonatal emergency, one of the cases of neonatal emergency, I would say.
Thank you, ma'am. So tremors with weight loss suggest thyrotoxicosis. Eye signs are suggestive of Graves' disease, and the treatment remains antithyroid drugs, and in the older children we can go for radioactive iodine. 12-year-old girl, there was a history of weight loss, there was tremors, FT4 was 34, TSH was less than 0.01, there was thyroid swelling, however there were no eye signs, there were tremors. What will be the plan, Dr. Alapan?
So this is a 12-year-old girl. I will come one by one. The FT4 level is high and the TSH level is low. So this is a hyperthyroid state. Now the girls have weight loss, tremor. So he is going into the thyrotoxic state. So now we have to rule out what is the etiology in this case. But considering the thyroid swelling that is present here, we might not do a scan in this child. This is a frank forward case of Graves' disease, and the treatment is available in terms of methimazole or antithyroid drugs. Propylthyroid uracil is not used in fear of hepatotoxicity in case of children. Another definitive treatment in this child that is present, that is radioactive iodine, which should also be cautiously used in risk of thyroid malignancy in that scenario. So as we can see, the nuclear scan guidelines are, so if there is increased uptake, if there is goiter and eye signs present, we might not do a thyroid scan in that scenario. But even if we do it in a Graves' disease, we can see an increased uptake of, enlarged uptake of thyroid swelling. In case of solitary nodule or toxic MNG, there will be increased uptake. The major differential diagnosis of Graves' disease, one is a thyroiditis. We should always rule out, and there is decreased uptake in cases of the nuclear scan.
So this patient had Graves, and she underwent antithyroid drugs with beta blocker and subsequently underwent radioiodine therapy. The key message that when there is weight loss, tremors, in case of with high T4 and low TSH, we should always suspect thyrotoxicosis. Eye signs are present in Graves' disease, and if eye signs are present, if goiter is present, we can avoid nuclear scan. And the treatment remains antithyroid drugs, and for the elder children, we can use radioactive iodine therapy. 8-year-old boy, there is a thyroid swelling. So Dr. Nathan, this thyroid swelling moves with tongue movement.
It is a midline swelling which moves with the tongue movement. So it is thyroglossal cyst, and because they get infected frequently, so surgically should be removed. So this is the treatment.
Thank you very much, sir. This is a 10-year-old girl. She had a thyroid nodule, and her thyroid function tests were within normal limits. She was euthyroid clinically, TPO were negative. She was reassured in that scenario, and subsequently the growth was found to be very rapid. So, ma'am, what will you think about this case, and what will be your approach?
Okay, so this is one condition which everyone is of. So now the thyroid suspecting thyroid malignancy, because she was reassured at the first instance, but there was rapid growth.
Yes.
So any rapid growth, if there is heart swelling which is fixed, if there is involvement of lymph nodes as well, and so definitely that suspects that this might be a case of thyroid malignancy, and this further warrants investigations.
Yes, ma'am. Thank you very much, ma'am.
Hello. Thank you, Aisha, and the rest of the panelists. So, I have a few questions to ask. I would like to know more about transient hypothyroidism, number one. Can at birth we can suspect transient hypothyroidism by any parameters? Or how do we go about its treatment? And how long the treatment is needed, and how do we reduce the doses?
Thank you, sir. Very, very pertinent question. So transient, मतलब जो आप scan कराएंगे या बाकी biochemical parameters. So like if there is absence of a thyroid gland, so definitely something which is going to be permanent. If there is ectopic, you're not sure. So the management is you have to start the treatment. Everything would remain the same dose and same type of monitoring. But you give thyroid medication at least for 3 years. And this is because this is the time when we believe that brain growth has been completed. So it's like not treating is not going to harm. Then at 3 years of age, you can take a trial off. Okay, if you have doubts, always start the treatment. You can stop the drugs at 3 years of age and stop it for 6 to 8 weeks and again check for thyroid access. And if it's again TSH is rising, then that calls for the treatment has to be given lifelong. Otherwise, so there are no pointers, I would say, except if you delineate the etiology, like its absence, so definitely has to be given. If it's dysharmonogenesis, if it's hypoplasia, so this is something like where you suspect there might be production of thyroid glands, thyroid hormones, so you have to give treatment if the TSH levels are high, and you can stop and take treatment off at 3 years of age. So that is.
Does the estimation of antibodies, I mean the blocking antibodies help? Yes, if the mother, say mother is having hypothyroidism, and estimating the antibodies in mother and child, does it help?
As TSH, still you have to give the treatment. So antibodies is not for prognostication, but definitely that will again give you a clue, because by 9 to 10 months, usually the effect of these antibody goes off. But you wait, if the TSH levels are very high, so you wait till the proper this brain development happens. So then you can always think about stopping. Okay, sure.
I'm sorry. Secondly, when you talked of acquired hypothyroidism and you showed the chart, we showed the symptoms of hypothyroidism, you did not talk of constipation. So my question is, can hypothyroidism can persist as an isolated constipation? Because this is such a big problem in clinic practice when you have lots of constipation.
Most common cause of constipation in children is always functional, but you have to just not treat one symptom, but you have to see the child in toto. So I would say, because there have been many studies in which I don't think constipation was a very significant complaint in all those epidemiological studies which they did. So most common, like there will be something else to add to your constipation. So you have to exclude functional first. If nothing works, then you have to look for thyroid profile. And if it's overtly abnormal, then why not, sir? This has to be treated. But just treating constipation and attributing constipation to sole hypothyroidism, I would say not a very common scenario. So everything else is fine. So
Do we look for, investigate for hypothyroidism, all the children in constipation or not?
Functional, then you may, sir. If that is the reason, the TSH would be definitely high with a low T4. They won't have subclinical or some dilemma-like picture. They'll have florid, but very uncommonly seen. They will have growth alteration. They have some cognitive impairment. They will have some associated feature along with constipation. So it's not warranted for single constipation, isolated complaint. So I don't think that's a recommended modality. For newborns, it says for 6 to 8 weeks after you manage 6 to 8 weeks, it has to be done. Once it's stabilized, the dose is stabilized, then you can do it 6 monthly. 6 monthly.
If the patient is already put on drug for hypothyroidism, congenital hypothyroidism, and do a thyroid scan after that, does it make any difference on the scan?
Yes, sir, it does. It does make a difference. So it should be done ideally within 14 days of starting the child on thyroid supplement. Otherwise, this does make a difference and lead to false reassurance, false normal report can be there if the child has been started on treatment. So it has to be done as early as possible, but you should not wait. Like scan is not available at all places. So if you suspect and think that this is hypothyroidism, the treatment has to be started. And it has to be done within 2 weeks' time, or you can wait till 3 years of age. If you want to, because that is just for ascertaining the etiology. So, but treatment, because the implications of not treating a newborn is very high. Adverse implications.
Sir, if TSH is later age, if TSH is still more than 30, we can do scan at that time only. Because TSH 30 means the scan will be positive if pathology is there. If pathology is there and TSH is 30, then the scan will come.
I don't know whether others also face like this. You order a thyroid test from different laboratories and you get different lab reports. Some may be like Dr. Lal or Ranvaxi or whatever. So how do you think that, which process? I think they all must be doing something, chemiluminescence or immunoassay. So what is important and how to interpret this? Which one is better?
They always write kindly correlate clinically. So you don't have ever to treat a report but the patient per se, but you also have to look at how, by which mechanism the test was done. So CLIA, CLIA is a good way, and you have to see, you have to see the clinical correlation as well. If there are any features which are correlating with abnormal your TFTs, then definitely treatment has to be started. But which lab is doing, I cannot say for sure. I'm sorry? Subclinical.
Thank you for broadening our horizons and fueling our curiosity. Now for the mementos to Aisha ma'am. To respected chairpersons, Dr. A.C. Chawla sir. To Dr. Ajay Srivastav sir. Now for the sixth session, I would like to invite our next speaker, Dr. Neha Agarwal ma'am. She is a consultant in Peadiatric Endocrinology at Regency Lucknow. And the chairpersons for these sessions would be Dr. Nirmala Joshi ma'am, President Lucknow Academy of Pediatrics, Dr. A.C. Chawla sir, and Dr. Ajay Srivastav sir. And for the panel discussion, I would like to invite the panelists, Dr. Lokesh Agarwal sir and Dr. Pragati ma'am.
Dr. Neha Agarwal, she is MBBS from GSVM Medical College, Kanpur, and Pediatrics MD from BHU, gold medalist in both the places. PDCC, Pediatric and Adolescent Endocrinology, Regency Kanpur 2017. And she is European Society of Peadiatric Endocrinology Fellowship, Alder Hague Children's Hospital, Liverpool, UK, and so many things are there. And she has many research contributions, also more than 20 national and international publications. And she is a co-author chapters in IAP textbook of Pediatric Endocrinology. Very nice. And ma'am, please go ahead.
Good afternoon, everyone. Good evening, everyone. Am I audible till back? Okay. So at the outset, I would like to thank Department of Pediatrics, KGMC, for the kind invitation and giving me an opportunity to discuss this important, pertinent topic routinely presenting in pediatric practice, which is pubertal disorders. So over the next 40 minutes, we will be covering both precocious and delayed puberty in boys and girls, with some cases to elaborate the physiology. So moving ahead, let us form a foundation before we start on the pathophysiology. So what we see here is a 6-year-old girl presenting with thylarchy or breast development. So before I begin my presentation, may I ask the PGs, is 6 years an appropriate age for thylarchy? Yes or no? How many hands for yes? How many for no? How many for yes? No. Okay. So let us see what actually is precocious puberty in girls. So this is a very common presentation, like it is mentioned here, 2.5% of all cases presenting may be precocious puberty in girls. And to our relief, 90% are physiological and only 10% have a underlying organic pathology. So here lies the importance of delineating those patients who have a physiology from those who have a pathology, so that we do not over investigate or over treat physiological patients. So once we have a case complaining of precocious puberty, or we are referred a patient with precocious puberty, so we will be talking what exactly is precocious puberty. Is the patient actually a case of precocious puberty? So by definition, onset of pubarchy or development of pubic hairs and thylarchy or breast development before the age of 8 years and vaginal bleeding before the age of 9.5 years is defined as precocious puberty. So from here onwards, just remember these two figures, 8 years pubarchy, thylarchy, 9.5 years for menarche is defined as precocious puberty. So before moving ahead, always check whether the patient satisfies these criteria or not. Then there are certain physiological variant or mimics which may be like precocious or early puberty, such as neonatal thylarchy. So because of the transplacental passage of maternal estrogen, newborns may present with breast budding, and this is neonatal thylarchy or a transient condition, does not require extensive evaluation and treatment. Then we have lipomastia, which is easy fat deposition in our areolar area. So nowadays obesity, overweight is on a rise, and so we get a lot of references for lipomastia mimicking as pubertal stage 2 or 3, and these cases are unnecessarily worked up as early puberty or precocious puberty. So how do you differentiate between a lipomastia and a true thylarchy? Any volunteer? Yes. So PGs, any volunteer? So by approximating the thumb and index finger, if you do not feel any resistance, then that is lipomastia. The third variant is pubic hair of infancy. So a very small child, 1 to 2 years, presenting with isolated pubic hair development, just wait and watch without any associated thylarchy or vaginal bleeding, does not require extensive evaluation. So precocious puberty in girls approach depends on the extent of the involvement. So there are forms such as incomplete. The girl may present with isolated thylarchy, isolated pubarchy and isolated menarche. So approach is different for these conditions.
And if the girl is presenting with complete pubertal development, that is breast development followed by vaginal bleeding, then the approach becomes different. So moving on to the complete precocious puberty cases, we have central or peripheral causes. So just touch basing the physiology, we have hypothalamus secreting GnRH, which triggers pituitary to secrete gonadotrophins, which then triggers the gonads to secrete estrogen. Estrogen works on the breast development, bone advancement, uterine development, leading to development of secondary sexual characters. So any abnormality which is GnRH dependent or at the level of hypothalamus pituitary comes under the central cause. So once you are suspecting central cause, think of CNS lesions such as hamartoma, tumors, glioma, hydrocephalus, arachnoid cyst. What is hamartoma? Heard of hypothalamic hamartoma? So it is just the presence of a normal tissue in an abnormal area so that it is not affected by the inhibitory signals. Then after you have ruled out the organic CNS lesions, workup for genetic conditions become next step. If the child has GnRH independent puberty so that the LH level is not elevated, only estrogens are elevated, think of peripheral causes. So these sex steroid hormones may be getting secreted from ovaries, adrenals, or there may be exogenous estrogen application. I will come to a case where you can see the example. So pubic hair examination becomes very important whenever we are examining a girl with precocious puberty. For example, if you have a girl with no breast development but pubic hair development, then what is it? Pubarchy. So this pubarchy may just be an isolated pubarchy without any adrenal involvement, or there may be elevation of DHEAS, which is the sulfated form of DHEA secreted exclusively from adrenals, known as adrenarche. You may have no breast development, no pubic hair development, but isolated vaginal bleeding. So think of a local cause, and before going ahead with hormonal workup, a gynecological referral is required here to rule out the local causes such as tumor, infection, abuse and trauma. Third possibility is breast development is there, but there is no pubic hair development. So this example was covered in our earlier talk, which was hypothyroidism. So very high levels of TSH may cause this sort of a picture. Then you have breast development followed by pubic hair development. So this is a concordant pattern of puberty, and this comes under central or GnRH dependent precocious puberty. So talking about hormonal progressions. So we have two gonadotropins, luteinizing hormone LH, follicle stimulating hormone FSH, and during the different stages of puberty, both these hormones undergo different pubertal hormonal progression. So as you can see here, so LH is the most important marker as it rises as you progress along the stages of puberty, whereas FSH has no role in identifying the early onset of puberty. So hence, whenever you are sending a biochemical investigation, LH is the main indicator and not the FSH. Also, the bioactive form of LH, there is a manifold rise as compared to the immunoreactive LH. And what are the cutoffs for LH? So baseline LH of more than 0.3 for children less than 3 years is defined as LH dependent precocious puberty, and if there is an intermediate level 0.1 to 0.3, then we do the GnRH stimulation test, and if the GnRH stimulated LH level is more than 9 in children less than 3 years, then it is defined as GnRH dependent precocious puberty. Similarly, for children 3 to 8 years, the cutoffs are different. It is 0.2 baseline LH and 5 GnRH stimulated LH. Now, what is the radiological progression of the reproductive organs during the different stages of puberty? So, as we see, what is the shape of prepubertal uterus? Anyone? So, prepubertal uterus is a tubular organ which can be easily missed on a transabdominal ultrasonogram, whereas a pubertal uterus is a globular structure which is unlikely to be missed on a transabdominal scan. So the shape of the uterus is an important character which is a radiological marker of pubertal progression. So just summarizing the approach, so if you have isolated pubarchy, girl presenting with development of pubic hairs, then always do a DHEA or the sulfated form of DHEA level. If it is less than 40, then it is just isolated pubarchy, no adrenal involvement is there. If it is between 40 to 135, then this is called as adrenarchy, which is commonly seen in SGA children with early catch-up or rapid catch-up. If the levels of DHEAs are quite high, then think of the adrenal causes, get a 17-OHP and a ultrasonography done. If the 17-OHP level is quite low, then the imaging may help you get a diagnosis of adrenal mass carcinoma. If the 17-OHP levels are intermediate, then getting a ACTS test is important or a stimulated levels. And if it is high, then it is diagnostic of 21-hydroxylase or CAH. So isolated pubarchy, get a DHEA. it may be just isolated pubarchy, adrenarchy, which is commonly seen in SGA children with rapid catch-up growth, or it may be a adrenal involved conditions such as adrenal carcinoma or CAH. If there is a vaginal bleeding isolated, then already is told it is a gynecological cause, no hormonal workup is required. Now, if the gonadotrophin levels are low, then that is hypogonadotrophic hypogonadism. Problem is at the level of hypothalamus or pituitary. Look at the CNS features and then get a MRI head done. If the testicular volume, if the gonadotrophins are low and if the testicular volume is less than 1 ml, then get a inhibin B level done. So we will move on to the cases and that will become easier to understand. So we have this first case of a 16-year-old boy who presented with pubertal concern.
Pubertal concern, the onset was around 13 years and stopped. It was initially started, the puberty started, and then it stopped for the last 2 years. Now he is having a testicular volume of 3 ml, soft testis and pubic hair stage of 3. Height is 170 centimeter and he was diagnosed as a case of CDGP. So Dr. Pragati ma'am, I would like to know whether you would like to proceed further in this case.
So that child has been labeled as CDGP, but there are some very strong pointers against the diagnosis of CDGP. Like, first of all, the boy is not at all short, height is absolutely normal. And second most important point, he has arrested puberty. He has stalled puberty. So CDGP children, they cannot have arrested puberty. There will be delayed onset of puberty, but it will not be arrested. So there is something else, some acquired cause which has arrested the puberty meanwhile in the course. So
this is the MRI picture of that child.
Yeah, so we can see that child has some neurological features because of that MRI was done. And here we can see the presence of large craniopharyngioma. So that child was basically having the central cause of delayed puberty.
So now moving on to the next case, a 17-year-old boy with pubertal concern. The onset was around 12 years and now it stopped for again 3 years. Now the testicular, this time testicular volume is 2 ml. It is a firm, salty testis and presence of gynecomastia in this child, which has led to come to the doctor in this child. Dr. Lokesh sir, I would like to know how would you like to manage this case?
So now a 17-year-old boy who had initially onset of puberty at right time, but that stalled due to some reason. And we have one clue that testis is now 2 ml and gynecomastia is there. So this is a very classical presentation of Klinefelter syndrome. Puberty had started and testicular volume, even if it reaches 6 or 8 ml, it again regresses down. And with that, gynecomastia is seen. So we will to confirm the clinical diagnosis, we will do one hormonal profile, FSH, we will see how it is, and if FSH is high, then we will do one karyotype also, and height also. Like in physical examination, we will see many clues already are there, which is suggestive of Klinefelter. So height is 182, so he is tall also. In behavior also, we can see some features of Klinefelter, and then we will do hormonal profile and karyotype. So
yes, the karyotype is showing XX point. Yes, as Sarah rightly said, the hypergonadotropic hypogonadism has much more chances of increasing gynecomastia in the child rather than the hypogonadotropic, and one should look for the karyotype in that scenario when we are finding a small salty testis with a tall stature and a stalled puberty-like picture. So that's all. Thank you.
Thank you everyone for igniting our minds with all your brilliance. Now the mementos. To the speaker, Dr. Neha ma'am. Chairpersons, Dr. Panelists. To Dr. A.C. Chawla sir, Dr. Nirmala ma'am, to the panelists, Dr. Neha ma'am again. Dr. Pragati ma'am. Okay, sir. Now, sir will announce the results of the quiz.
So we'll have the final, I think at the end of it, it was a wonderful program. And it was a long one, but I think everybody was there. So many people are there from the beginning. So the quiz was difficult. It was meant to be difficult. But we have got good participation from different people. So that is a big part, I think, a big round of applause. So before we start off with the prizes, a special prize to Dr. Lokesh, who got the highest marks. But he's a faculty, so we're just going to give him the books, please. Dr. Lokesh. So for the practitioners, we have got 2 awards. First one goes to Dr. Anshika Mishra. So she has been here since morning and she has done really well. So we'll give the award to her, and the course also will be activated subsequently. Dr. Vidhur. Yeah, please. So Dr. Vidhur is the second in the it's the practitioners part. So they are both senior residents? Yeah, please. Yeah. Okay, great. And for the trainees, we have got Dr. Najish from IRA Hospital. So Dr. Najish is there. So she was the first in the trainees category. So we will activate the postgraduate course and the books, basic and protocols. And Dr. Tanya. Dr. Tanya is there. Yes, definitely. And Dr. Deepika. Deepika is not there as well. Yeah. So I think it was a wonderful program, and I think we need to give a big round of applause for Dr. Arpita, who has been continuously working for such a long time. And I know it's such a hard work. So I think thanks a lot, Dr. Arpita, for that. Yeah. Over to the organizing team.
Now, as we come to the end of this program, I want to take a moment to express my appreciation for all of you who have joined us here today. On behalf of everyone in attendance, I want to express our sincere gratitude to our speakers who have generously shared their knowledge. Finally, I want to thank the organizers of this program for their hard work and dedication. As we go our separate ways, let us take with us the lessons and insights we have gained today. Let us continue to engage in meaningful dialogue and work together to create a better future for ourselves and future generations. Thank you and have a wonderful day. Now, I would like to request everyone to please come on the stage for a group photograph.
अच्छा